So welcome to this CME on infection prevention and control in CSSD. And before we proceed, for those of us who are not from Hospital Infection Society Mumbai Forum and even otherwise, just a brief on what this forum is about and what we have been doing for all these years. So in the next 1 or 2 minutes is what I would like to proceed with. I'm Dr. Geeta Natraj, currently working in the Department of Microbiology at St. J.S. Medical College and KM Hospital. This is a forum that was established in 1985, and the founding members were giants in their respective fields, and they were the ones who were responsible for taking it ahead and making us as a cohesive unit for more than 3 decades now. So these are some of the major contributors to infection prevention and control, not just in Mumbai but also in our own country. Dr. Ajita Mehta spearheaded this along with Dr. Vidya Acharya. Both of them are no more with us, and their contributions, they have left a legacy that probably is very, very difficult to fill. We also have late Dr. Ari Balera, who was the clinical driver for this kind of forum, and we still have Dr. F.D. Dastur with us, who though he's not currently actively associated with the forum. And one of the maybe not the exact founding member, but who joined very early in this forum and who was responsible for conducting these activities, Dr. Rohini Kelkar. You will be meeting her sometime during the day, and she speaks to you about this. The objectives of this forum are primarily to kind of initiate activities to understand better and to practice better the infection prevention and control measures for prevention and control of healthcare associated infections by conducting awareness sessions such as today, by conducting actual training either online or offline. Online is something that we have been doing since the last 2 years. We were not used to this concept before, and even certain workshops we have held for skill development. We probably have completed about 169 meetings where multiple discussions are held on specific themes. There are lectures, invited faculty. We have conducted CMEs, workshops, and we have also held one of the national conferences of Hospital Infection Society India. The objective also is to formulate policies, and we have 3 or 4 policies with reference to practices in operation theatre, with reference to reprocessing of medical equipment, with reference to biomedical waste, and so on. We currently have about 316 life members, 54 annual members, 42 institutional members, 5 institutional annual members, and 14 patrons. And I'm thankful to all of them for making this forum what it is today, and for keeping this forum active, because without members' participation, nothing will ever move. And for today's session, we are thankful to 3M India Limited, Raman and Veer, and Advanced Sterilization Products, who have kindly accepted to sponsor this particular CME activity. Now I hand over to Dr. Aruna to take this proceeding ahead.
Good afternoon, everyone. And we will start off with today's session. So I'm going to introduce Dr. Vidya Nerokar. She is the Director of Quality Assurance and Certification Programs and the Head of Microbiology at GenePat Diagnostics India Private Limited. She is an MD in microbiology with 17 book chapters and publications to her credit. Her interests being tuberculosis, immunology, and quality in microbiology. Dr. Vidya, it's a pleasure to have you as a coordinator for this particular session. Please carry on with the session.
Good afternoon, everybody. Thank you, Aruna, for that kind introduction. Without much ado, I would like to begin today's session. So, to begin with, I think each day, millions of medical procedures are performed across healthcare facilities globally. And patients' caregivers primarily rely on the availability of appropriate and adequately cleaned, disinfected, or sterilized supplies, instruments, and equipment. So the CSSD, or the Central Supply Sterile Department, plays a very humongous role in providing these items. while ensuring the quality of the equipment provided. So each task becomes very paramount in upholding the good infection control practices within the facility, not just for the welfare of the patients, but also for the staff and community in general. So to reiterate the importance of this very critical function that the CSSD plays, we have our first speaker deliberate on the importance of CSSD guidelines and recommendations. The first speaker is going to speak is Dr. Lona Dash. She is an additional professor with the microbiology department at St. G.S. Medical College and KEM Hospital. She is an MD from Mumbai University, a very, very active and a very responsible teacher. She has about 25 years of experience in UG teaching, 15 years in PG teaching. She has several peer-reviewed national and international journals to her credit. She is a member of the KEMHIC. She's a reviewer. She very, very actively is a part of organizing CME's workshops and is also an executive member in a number of other committees and institutions. Her primary interests are hospital infection control, AMR, diarrheal diseases, and fungal infections. So, without any further delay, I will hand over the podium to Dr. Lona.
Thank you, Dr. Vidya. A very good afternoon to my respected seniors, Geeta ma'am, Rohini ma'am, my colleagues and friends. And at the outset, let me thank Geeta ma'am, Dr. Aruna, Dr. Shweta, and Dr. Vidya for this beautiful opportunity to speak on such an important topic at today's very, very relevant webinar. I shall share my screen now. So the topic for today is importance of CSSD and the various guidelines and recommendations thereof. Scope of my talk will include introduction, articles that are sterilized in the CSSD, functions, importance of CSSD and the various activities and functions it undertakes, and guidelines and recommendations. So to introduce the topic, when the word sepsis was coined and came into an understanding, it brought about a greater understanding and the importance of maintenance of asepsis in the various surgical procedures and invasive procedures. As we know now, a key component of hospital infection control and standard precautions is the use of sterile instruments, drapes, gowns, and dressing material in patient care, be it in the OT, on the operation theatre, or in any other setting in the hospital. So who are these angels who provide these sterile items for patient care? To begin with, in most hospitals, individual operation theatres, individual departments or units take up the task on their own in their own setup, which is still the norm in many hospitals. However, when these activities are conducted in a centralized manner, it gives rise to this very special and important department called the CSSD, which is the Central Sterile Supply Department. So this is the service which centralizes the activity of receiving, storing, processing, and distributing sterile instruments and materials for surgeries and for invasive procedures, which are delivered in and which help in delivery of a safe and infection-free quality care to patients in the hospital. All these are done as per a very important, well-delineated protocols and under strict quality control. So the CSSD effectively provides efficient, economical, continuous, and quality supplies of sterile materials and instruments to various units in the hospital. Historically, the first CSSD was started in the American College of Surgeons way back, almost a century back in 1928. The modern concept of CSSD came into force and gained popularity during the Second World War. let's look into what are the various articles and supplies which are provided by the CSST to the hospital. Does it make sense to have a separate department dedicated solely for this purpose? If yes, then what are the guidelines and important recommendations that need to be kept in mind and that need to be followed? The articles that are generally commonly provided, sterilized and provided by the CSST include diagnostic sets like the lumbar puncture set, sternal puncture set, treatment sets like the cut down tray aspiration set, OT instruments and linen, various scopes like the cystoscopes, bronchoscopes, heart-lung machines, dressing material including gauze, cotton pads, swabs and sponges. Very importantly also, rubber gloves and gowns, drapes, towels, bowls and trays, which are very important to be sterile because they are kept in the sterile precincts of the operation theatre or the invasive procedure. Coming to the importance of the CSST, the role of a central supply sterile supply department which caters to the whole hospital in a very standardized and safe way cannot be overemphasized. There is a great role in minimization of hospital acquired infections, and the process is done under quality assurance and quality control by qualified and designated staff. As the staff are catering solely to this department, it takes away from the burden and workload of the nursing personnel who would otherwise be involved in doing these various chores in their own units. Hence, they are better able to contribute to the nursing care. Also, it helps to avoid duplication of costly equipment and instruments, as the instruments can be provided to different departments based on their time schedules, and therefore it helps in conserving the resources of the hospital and is financially beneficial to the hospital as well as economically beneficial to the patient because it reduces the hospital stay of the patient. The aims of setting up a CSST are to prevent cross-infection in the hospital. It thereafter reduces the patient's hospital stay by providing a safe environment not only for the patient but also for the staff to work in. There is delivery of quality care and standard care, and this also helps in inventory maintenance because the instruments and equipment are inspected by the CSST to make sure that any damaged instrument is either repaired or condemned. And all this is done in an economically efficient and uniform way, thus leading to supply in a very standardized way of quality sterile supplies and instruments. Various functions of the CSST and its activities are laid down here. Basically, the CSST works in collaboration with the Hospital Infection Control Committee and functions as per the hospital policies and programs. It does the work of receiving all unsterile, reusable items for sterilization, and it sterilizes the required items, the articles, instruments, and packages them in and labels them, and then undertakes the sterilization process. Thereafter, it ensures a timely supply of these items to the various OTs and labor room and other units of the hospital, and helps to maintain a continuous supply of sterile articles. And thereby, it contributes to reduction in the incidence of hospital-associated infections by preventing cross-infections. It also maintains a record of effectiveness of the cleaning, disinfection, and sterilization process, and helps to avoid duplication of costly equipment. It also organizes training for hospital personnel related to utility and utilization of the sterile supplies, and also trains its own staff at recruitment and from time to time. Also, it is involved in conduct of research activities for improvement and upgradation process, and it stays updated regarding developments in the field of sterile supplies. Also, it monitors and enforces controls to prevent cross-infection and provides a safe environment for patients and staff. All these functions and several of these topics will be taken up by subsequent speakers in a little more detail. And therefore, coming to the overall activity and workflow in a CSSD, after receiving the unsterile instruments that are usable and that need to be sterilized for further use, it undertakes the process of sorting and checking and inspecting these, and undertakes cleaning, washing, cleaning, and decontamination as required. Then thereafter, it inspects the instruments and supplies for any damages, and wherein it would then send it for repairs, or if the instrument is not repairable, it would send it for condemnation. And which all the instruments that are in good quality and in good shape are thereafter packed, labeled appropriately, and then they are sent for sterilizing. Once they are sterilized, they are stored temporarily in proper cabinets or shelves, and thereafter the important task of supplying these, distributing and dispatching to the required hospital areas are undertaken for them to be reused purposefully. Thus, there are certain things which need to be kept in mind while designing a CSSD, the important points being the size and the location. There should be ample space provided for the department, and which would actually depend on the number of beds in the hospital and the operation load in the hospital. On an average, 7 to 10 square feet per bed is what needs to be allocated for this important department. It should be located ideally in close proximity to the operation theaters and labor room and wards and ICUs, which are the biggest users of the supplies. The layout should be designed in such a way that there is a unidirectional flow from dirty area to clean area to sterile area, with physical barriers between these, so that there is no cross infection while in the CSSD. Therefore, the 4 zones which may be demarcated are the unclean and washing area, the assembly area, packing area, and sterilization area, which would constitute the clean area, and thereafter the sterile area with effective barriers. Each of these has equipment in place in order to perform functions towards sterilization of articles for immediate use in patient care. The staffing of the CSSD is critical. There should be a supervisor of the CSD or a manager who looks after or supervises the overall tasks and chores at the department. There should be trained technicians for each of the important chores and running the important equipment, and they are helped by attendants and assistants who help in cleaning, labeling, packing the different sets. The clerk or storekeeper would be necessary to keep an inventory and maintain stocks of the various instruments and the various packages. Housekeeping staff are, of course, required to maintain cleanliness and disinfect the CSSD department as required. Hand hygiene and use of appropriate CPP is mandatory for the staff. Therefore, some of the requirements of the CSSD would include cleaning and decontamination facility, sterilization equipment, and storage cabinets for temporary storage of the sterile packages. Very important component of a CSSD is quality assurance. And this is done through use of various sterilization controls like the mechanical indicators, chemical indicators, and biological indicators, which will be dealt with in subsequent talks. Modern equipment are fitted with good quality monitors. Printouts of each cycle are provided, which help in visibly making sure that these have been catered to. Sometimes in many of these autoclaves nowadays, they do not open unless the cycle is complete. Again, a good way to ensure that the various parameters have been met with. Coming to some of the recommendations and guidelines of a setting up of a CST as well as for a functional CST. Needless to say, all policies and procedures to be followed in a CSST should be documented in a SOP manual. The procedures should be such that they ensure the disinfection and sterilization process, that these are followed as per the principles of the infection prevention laid down by CDC, by WHO, or by the national guidelines. These policies manuals should be readily available to the staff for ready reference, and the workflow should be put up on the walls and put up so that their work desk instructions are available, and these must be reviewed annually or more frequently if necessary. Documentation and maintenance of all records, including the cleaning, the disinfection process, the issue process, to which departments it has been distributed, which departments have sent back the dirty and contaminated instruments and articles. All these have to be documented very scrupulously in the records. Ongoing audits of competency and procedures and obtaining feedback from the clinical departments is again a very necessary part of maintaining quality assurance. Procedures followed for recall of instruments as necessary should also be laid down. The CSSD requirements for NABH need to be followed, which again would include largely the points that I have mentioned so far. And it's very important that the documentation is done very clearly, continuously, and scrupulously. The staff should follow standard precautions, including hand hygiene, including proper use of personal protective equipment. They should be trained in prevention of sharp instrument injury, and because many sharp instruments would be there in the packages, and they should also be made aware of what to do in case of an unfortunate incident, and should be made aware of post-exposure prophylaxis. What's new in the field? Technology that tracks the instruments from the procurement stage throughout the cycle that it undergoes have been developed. And these are going to be very useful in maintaining the inventory, in ensuring continuous supplies. Summarize, the CSST provides and supplies sterile instruments and other items used for operations and invasive procedures. It receives, checks, cleans the instruments, and maintains an inventory. The CSST monitors and ensures sterility necessary to prevent cross-infection, and thus plays a very important role in prevention of hospital-acquired infections. To conclude, in healthcare facilities where the CST is present, it plays a key role in delivery of quality healthcare. A well-managed, well-planned, and well-staffed CSST can save the hospital's resources, as also of that of the patients, by contributing to infection prevention and control, and also by preventing duplication of costly instruments and equipment. While the CSST goes about its job in a thorough and professional manner, needless to say, the healthcare workers at the patient's bedside must follow these 5 moments of hand hygiene as relevant. With this, I thank you all for a patient hearing, and I thank you for the opportunity.
So thank you, Luna ma'am. That was lovely. It's a very good overview of the importance as well as the guidelines that one needs to adhere to while getting on with the CSST. I would just thank Dr. Luna for taking out the time and giving us this deliberation. There are two announcements for everybody. Firstly, any questions that you would have on this topic, kindly reserve them. We will be taking all the questions at the end of the session. So please write down and note them. Secondly, a sincere request to all the participants to please ensure that they are on mute so as not to disturb the speakers and disrupt the flow. So please take note of that. So moving on to the next speaker. I think the first presentation pretty much kind of sums up that service excellence is absolutely an intrinsic requirement for the CSST, considering the important role it plays in infection control. However, I mean, if you know the management guru Peter Drucker, he said this: you can't steer what you can't measure. And I think it's very important for us to understand the ability to formulate, measure, and monitor quality as a very important component to see if we are going in the right direction. So implementing KPIs or key performance indicators, as it would be called, helps achieve this objective. And if these KPIs are used correctly, they are like a super tool in measuring efficiency and also essentially gives us the tools to take very stern, strong operational decisions. So addressing this very essential component, we have our next speaker, Mr. Ujjwal Chakraborty. He's going to be speaking to us on key performance indicators in CSST. Mr. Chakraborty is a consultant in medical device reprocessing, L&Ds, hospital projects. He's an MSc MBA, CRCST, CPQIH, PGDHA, and an EDP he's done an EDP from IIM Bangalore. He has been instrumental in conducting CMEs and trainings and is very actively involved in a consultancy. He has numerous publications in terms of white papers as well as newsletters. He also is a teaching faculty for the various courses, and his primary interests are learning, development, and transformation. So over to you, Mr. Chakraborty. We are waiting to listen about KPIs from you.
Thanks a lot, Dr. Vidya. Hope I am audible, right?
Yes, you are. Please go.
Thanks a lot, madam. Good afternoon, one and all. And thanks a lot for giving me this opportunity to this great forum so that we can share and we can speak. That's really great. So I'll be sharing my screen. So whatever we will be discussing, as we know that we are very much related to evidence-based. So these are some of the guidelines or some of the links that I refer to whenever there is a need for any discussions related to instrument reprocessing. So I suppose all these pictures are very common, and starting from our inception or the generation of these sterile items as well as distribution, the training, be it water quality, everything is there in this picture, right? So I will not waste much time related to the workflow. As we all know, these are the main workflow, and this is a very basic things that we do every day. But what the point I would like to share is the bullet or key terms in terms of SUDs, in terms of WIM, in terms of SOPs, in terms of IFUs, if you talk about HVACs. So all these are actually very critical in nature. And when we talk about KPI or key performance indicator, so basically key performance indicators are something which we need to evolve, because if you talk about CSSD field, there are lot many things yet to be done. Because if you go through the NABH 5th edition also, you can see that there is one chapter that is HIC 7, and the objectable events are from A to E. And even before NABH also, we have not received any kind of CQI or continuous quality improvement or some kind of measuring the CSSD practices. So if you really want to prepare the KPIs, you need to prepare your KPIs on your own. If you talk about guidelines, at least NABH will guide you only to have proper position and different segregation of workflow areas. All those things can be there, can be addressed through NABH 5th edition. But if you really talk about KPIs you need to build on, and you can build KPIs, n number of KPIs in different work areas and work protocols as well. So as we know that basically these are the something called as your main architectural design, wherein you are having mainly 3 blocks. You have not shown any ancillary block. So the KPI that you can build here is unidirectional. So you can easily understand that whether you are actually unidirectional in terms of infrastructural facilities or it's a crisscross happening, because most of the CSSDs previously was unplanned. Even today's world also, we are trying to plan CSSDs, but somehow or some way or other, we at the end of the day, we actually fail to plan the proper infrastructure in terms of unidirectional workflows. So if you talk about handling collection, transport of different items, there also you can build on some KPIs. Like I would like to say you that we need to focus on this Spalding classification, as we all know. But when you try to prepare KPIs, what kind of KPI or what kind of points you can prepare or you can come across is starting from your primary cleaning. As soon as the OT is over, we are trying to do the primary cleaning, right? Now, what kind of KPIs you can build on this primary cleaning activities? So what happens as soon as the case is over? Either in most of the scenario, they are directly coming up all those instruments with the open trolley in CSSD, or even if there is some position, some of the many hospitals I have seen, even they are doing the primary cleaning where they are scrubbing, where the surgeons or the technicians or the nurses are scrubbing the same scrub sinks they are using for primary cleaning. If that is the case, we need to understand what kind of KPIs. KPIs can only be built if infrastructural supports are there. So it's very easy to build on a CSSD when you are actually trying to build a hospital. But once the hospital is already built up, once it is on a running stage, doing so many activities related to infrastructural corrections is very, very difficult and next to impossible. Now, when you talk about transportation, some of the hospitals are having directly connected lifts. So what kind of KPIs you can build? You can measure that during transportation, are you contaminating the transporting paths? During transportation, are you facing difficulties or challenges in terms of reaching items or in terms of increasing your TAT? So all those things, every hospital is different, every infrastructure is unique. So you need to come up with your unique KPIs, right? So that's a way to go forward. If you talk about segregation also there is a KPI mandated, because suppose if you are using in the CSSD, if you are using different agents that may be of neutral pH, that may be of acidic, or that may be alkaline. So depending upon your pH, also depending upon the material compatibility, also you can also refer that kind of KPIs, whether the technicians, how many times they are deviating from the SOPs, or they are deviating from different kinds of work instructions manuals that we have ensured. So if you talk about dilution, if you talk about temperature, if you talk about EVN or environmental control, so all these parameters, be it hand hygiene, be it PP, so everything we can measure. So only thing is that we need to start preparing all those KPIs depending upon our infrastructure. Now the problem is, we know that there will be some KPIs wherein we will not do good results, and there will be some KPIs where absolutely every time, most of the time, we will be succeeding. Like if I am giving an example, suppose if you talk about biological indicator test result, and if you try to build a KPI on biological indicator test result, believe me, most of the time or all the time, you are going to get the BI test result as satisfactory. So building on KPIs which you will always get a satisfactory result, or building on KPIs actually to monitor or actually to measure or actually to improve your work practices, you need to decide. So these are some of the pictorial representations. We can transport through wet disposal or dry disposal. We can transport through a closed container. We can transport. So each and everything we can measure, each and every activity, there is a scope that we can build on KPIs, right? So these are different kinds of instruments having different exposures and having different issues with it. Some of the instruments are having some blood stain, some of the instruments having some different discoloration. So my upcoming speakers will be definitely focusing on all those reasons of different kinds of things. Actually, CSSD technicians are not magicians. So most of the time what happens, a new instrument is purchased and suddenly they give it to the CSSD for sterilization. Now once sterilization is done, when they open the instrument, some of the time or most of the time they see that some rusting or some discoloration happened to the instrument. So basically persons who are working under CSSD banner, they are not magicians, they are not doing some activities. So it's about your water quality, right? So those, all those things we need to be very careful, and this kind of pictures are very common, right? So we are just trying to load instruments in a very jumbled format. So I'm not going into the details. So what I mean to say in this picture is, if you see a very small tiny instrument that is called a Castro Caesar, and which may be costing you anything beyond 1 lakh plus Indian money. Now, if you want to use a toothbrush for cleaning this instrument, I don't know what kind of KPIs you can build on all those things, right? So this is a water quality chart. We are referring from EN 285 standard. Now, if you see, every now and then we talk about RO water. So that is RO is not a water. RO is a process, right? We are having RO water as our drinking purposes. We are having RO water for dialysis procedures. We are having RO water for different other practices as well. So what kind of water parameters we are looking for? So this is the parameter we need to be very focused on understanding what kind of water quality we really require for our sterilizers to perform, right? So these pictures are very common, right? Most of the slides I prepare or I present, I keep this picture because this has been taken from one of the hospitals during my visit. So they were written, they have written as zero infection hospital. Now, if you see the cleaning accessories and they were using this kind of instruments, now you can imagine with the help of this kind of accessories, if they want to reprocess this kind of critical complex instruments, at the end of the day, what kind of KPIs you can build, you can understand. So building KPIs depends on upon our institute, what kind of practices we are dealing with. So all those things are very much required, and for that we require this kind of critical complex different kinds of items, be it our wash stations, be it ultrasonic cleaner, be it different kinds of brushes. So all those things are required. Now, if you really talk about sterilization process and based on that some KPIs onto it, so you can prepare a KPI on material compatibility. We can prepare KPIs on calibration. How soon we are doing the calibration? Are we just doing the calibration only to pass or succeed audits like NABH or JCI or XYZ? Then it's a different ball game we are doing, right? Now we need to build on KPIs on wet packs. We can build on KPIs on HVAC or environmental controls, be it water quality, be it the purity of compressed air, be it the cleanliness, overall cleanliness, be it loading or unloading of sterilizers. So everywhere, every step we can build on KPIs so that we can monitor and we can try to improve from where we are and from where we are to where we can go, or where we can set our own benchmarks, right? So if I talk about little bit of actual or practical examples of different KPIs, so this is the slide we can think of. In general, we need to be very focused on training and development. Now the point is, the problem is there is a term called CNP, and that is credentialing and privileging, right? And it is very much common if you talk about clinical settings, be it a clinician or be it even nursing. This credentialing and privileging is already there. But in CSSD, hardly there is any credentialing and privileging. And now you buy a very complex instrument, which may be costing 4 lakhs plus, and you don't have any kind of training sessions or anything done for that particular poor guy who is working in CSSD. Maybe you have done a number of trainings for the particular surgeon or even the nursing. Now, once the surgery is done, that particular item, maybe 10 lakh plus item, has been given to CSSD technician just to reprocess, and during reprocessing, as they don't know maybe it is a multi-part instrument, so they don't know how to dismantle or how to assemble it, and eventually they damage the item. So this is directly impacting. Now the blame game starts, right? So nursing says that it has been done by CSSD technicians, and technicians are saying that it has been done by nursing. So at the end of the day, the pain point has to be borne on by the hospitals, or sometimes even by the patients who are coming up with great belief and great trust. So CNP is going to help us in a very larger way. If you talk about risk or contingency planning, we actually need to do HIRA for our own institution, and that too for CSSD, and if possible IFE, FMEA, right? Failure mode and effect analysis, right? So all those things are very much required if we really want to improve our day-to-day practices. If you talk about equipment troubleshooting, most of the time we know what kind of common troubles are there from that equipment, but hardly we are having any chart or any reference so that our technicians can refer to the chart and can do the needful. So there are good companies who actually provide this kind of troubleshooting of different reference charts. But for indigenous companies, we can prepare our own charts, right? Understanding different kinds of scenarios with the help of biomedical engineer and company representatives, we can definitely prepare our own charts. And we also need to know the escalation matrix. If there is any problem, where to escalate, how to escalate, right? Now, coming back to some of the practical examples of key performance indicator to measure, like the total number of packs we processed due to wet pack. So how many wet packs we are getting every day. So if we can monitor, and subsequently if we can do the RCA or the root cause analysis, and then kappa or the preventive and causative and preventive action. So all those things, and we can do with the help of that kappa and RCS. Now, total number of items or instruments misplaced. Now, most of the time, what happens, either sponge holder or different towel clips are misplaced, because those are there with the linen, and when they send the linen to the laundry, some way or the other, they discover the item is there in the laundry. So now, if we can measure all this, if we try to measure, if we build on practices, in my last speaker who has rightly mentioned that the new thing is that we are now tracking and tracing each and every products and processes. So if we can really do that, that will actually help us to minimize different errors, right? Now, if you talk about other examples, like number of items damaged due to improper sterilization or process selection. So material compatibility plays a very major role. If we don't know that what kind of items, we cannot give it to the autoclave, then at the end of the day you will be damaging the item, right? So thermoliable and thermosensitive, these are the two terms we need to be very focused on, and we need to train our staffs accordingly, right? Now, number of deviations observed where the clinical steps of reprocessing were bypassed. Now, what happened? So, suppose a set is containing 50 plus instruments. Now, during surgery, maybe they have used 10 or 20 instruments. So, remaining 30 instruments, they may be thinking that let's not reprocess to cut down the time, or to shorten the time and achieve the proper TAT. So those kind of things we can always measure, and we can always prepare some KPIs. So documentation is actually playing a major role. Percentage of staff having proper knowledge of reprocessing. Now we all know that the person is working for last 10 years. Maybe they are working for 30 years. That's not a matter. But if the instrument is new, if the instrument is complex and the training is not done and CNP has not been taken, then it's really very difficult to deliver quality services at the end of the day, right? So next one, maybe number of surgeries cancelled due to unavailability of instruments or improper reprocessing. So all these items we can measure and we can start achieving towards the best practices set up by all different hospitals and healthcare institutes, right? So last slide is that is the main thing. We need to prepare. We need to come up with documents and prepare data. So there is a very good line called "In God We Trust, all others must bring data." Right. So thanks a lot for your kind attention and patient hearing, and thanks a lot, madam, for giving me the opportunity to speak in this August and in this very eminent forum. Thanks a lot. Thank you.
Thank you, Mr. Ujjwal. That was a very brilliant practical knowledge that you shared with us on KPIs. And I think I love, on a personal note, I love your last slide. And I think I'm going to use that quote, "In God we trust, others bring data." I think that's a take-home message wherein we need to train adequately. We need to do competency assessment adequately, and yes, train people to document data correctly. So thanks a lot, sir. Very valuable lecture. We will now move on to the
Thank you,
next
madam.
session. We will now move on to the next session of topics. Dr. Shweta Shah is going to be taking over as the coordinator for the next session. Dr. Shweta Shah is, she needs no introduction, of course. She's a very eminent microbiologist. She's done her MD microbiology from Sion Hospital and currently is the consultant in microbiology and infection prevention at Kokilaben, the Rubai Ambani Hospital and Research Institute. So over to you, Shweta, for the next session.
Thank you, Vidya. We have had some brilliant session, and I will not waste any time. We start with Dr. Aruna. Dr. Aruna is heading laboratory at Bridge Hospital, has a degree, various degree in microbiology, pathology, and infection control, has multiple papers which is kind of reaching in 3 digits now, and has a brilliant teaching experience. A very, very good friend. Aruna, over to you for the kind of literature review, because that is very, very important as far as CSSD goes. Thank you.
Okay, thank you. And I think both my previous speakers, Dr. Lona ma'am and Mr. Ujjwal, have actually set the stage to what all things must be done. And I'm going to simply re-emphasize the same, giving some practical examples, both from India as well as at a global scale, which further is going to, emphasize that yes, we need to follow practices as a standard. So this session is titled Clinical Implications of Lapses in Sterile Supplies Services or Practices, a literature review. So I'm going to be shortly discussing the Spaulding's classification once again, the importance of sterile supplies, the lapses that might happen in the sterile supply cycle, literature reports which will be restricted to semi-critical and critical devices. What are the reasons for these lapses, and then overcoming these challenges. So once again, coming back to the Spaulding's classification, we know that it is various devices can be classified as non-critical, semi-critical, and critical, and depending upon where exactly is it is being used on the human body, and what would be the disinfection or sterilization practices that need to be done in order to handle these equipments and ensure that they are safe for being used on another patient. So for this particular talk, as I said, we'll be looking at the semi-critical, which is basically instruments that pass through mucous membranes or non-intact skin. So these are areas which are likely to have normal or commensal flora. And here, at a minimum, high-level disinfection, meaning up to mycobacteria, should be dealt with. And the critical ones are those that enter into the sterile body surfaces or the vascular system. And here here nothing less than sterilization is acceptable, where vegetative as well as spore forms of organisms need to be destroyed. So one of the most important things that as an infection preventionist would be important to us as from sterile supplies would be to avoid any kind of infectious complications. And we know that while SSIs have a lot of other things that may be responsible for SSI, equipment sterilization and disinfection remains an important and a major chunk. And as a result of which, there are bacterial infections, there are infections due to non-tuberculous mycobacteria. There are also infections due to bloodborne viruses like HIV, HBV, HCV, parasitic infections, fungal infections, and we'll see some of the examples in the coming slides. And this is a nice report coming from ECHE, published in 2014, which said that up to 60% of surgical site infections are actually preventable, and a large chunk of this is actually due to improper sterilization and disinfection of equipments. Now, the sterile cycle, as you see, sterile supply cycle, as you see here, is basically a cycle which has multiple steps, has many team members who are involved, and therefore is very likely to be complex in nature. Now, at every step, there will be there needs to be meticulousness and there needs to be perfection. Otherwise, even one single step where there is a lapse can actually affect the whole cycle. So right from preventing soil from drying onto equipments, insufficient cleaning, not following manufacturers' recommendations, not allowing adequate time or concentration to your process, improper loading, improper packaging, all of these are going to affect, either singly or collectively will affect sterile supply cycle, and thereby lead to a complication which is going to harm not only the patient, the institution as such. So every step in the journey of an equipment through the sterile supply cycle actually matters, and it should be done meticulously. So what are the consequences of any lapses in the chain? Naturally, patients are put at a risk of contamination. We tend to then investigate outbreaks of infection. We know that by itself can be very resource draining. There's a potential loss of accreditation, bad publicity, damaged reputation, loss of business, and of course litigations, as is seen in this particular slide. So this was a lawsuit filed against a hospital in Colorado where surgical instruments were actually found. There were lapses in the sterile supply services, and patients had hepatitis B, meningitis, infections due to staph, and in fact there was also mortality associated with this. Similarly, litigations are also the reality whenever such matters come into light, and therefore it is very important that we ensure that proper procedures are followed. Now, while we often look at the whole sterile supply chain pertaining to hospitals, I think it's very important to also understand and for us to be conscious of that it's not only restricted to hospitals, but it also extends to primary care and ambulatory services in the community. So while we focus so much on the hospital, sterile supplies play an extremely important role both in primary care and in the community, where we do mass daycare procedures, for example, cataract surgeries, etc. And we know of so many reports in India itself where endophthalmitis has resulted from camp-based surgeries. And in these areas also, this particular topic is very important. So what is really the extent of the problem? And this was a very nice and interesting report that I came across from the Joint Commission, which did an on-site survey to find out what are the meaning how much is the extent of non-compliance with respect to IPC in the sterile services department, and they found that hospitals of 51%, 58% in critical care, critical access hospitals, ambulatory 43%, and office-based surgeries 53%, which is, meaning quite a bit. And 74% of all of these ITLs are basically immediate threat to life. Related to improperly sterilized or HLD equipments. And this might naturally in turn lead to outbreaks of a variety of things, including viruses as well as bacteria. Closer home, this is a study from Nepal which looked at audit findings in the process, in reprocessing and steam sterilization of reusable medical devices, and not a surprise that the practices, the non-compliance is really high. And similarly, another paper from India itself, again coming from primary care facilities where female sterilization services have been are being offered. And as you see here, staff responsible for sterilizing equipment, their training basically is in infection prevention is only 45%, and used sterilized equipment for every observed case is only 74%. So there is a huge gap. There is need to do something about it, and to understand that these practices are important and need to be followed. Now, moving on to some literature review, and first let me start off with HLD related services. And this is a very recent document that looked at medical device sterilization and reprocessing with respect to MDR bacteria. And while bronchoscopes and duodenoscopes actually go through HLD, cystoscopes and ureteroscopes are supposed to be critical, and they often go through sterilization. And as you see here in this paper, from 2015 to 2019, the number of recalls due to microbial contamination have only increased over the years. This is basically US data, and this is because of microbial contamination. Now, this microbial contamination is mainly important from the point of view of maybe device design, because many of these minimal access devices are actually complex in nature. They are far more complicated, and unless proper cleaning is done, one is likely to encounter a whole lot of organisms, including bacteria, viruses, parasites, fungi, and so on. Another very important and very good article that I also came across was this Clinical Microbiology Review article from 2013, which looked at flexible GI and bronchoscopy and various infections associated with it. And as you see here, there are a whole lot of bacteria, and the main reasons have always been cleaning, disinfection, improper sterilization. Of course, the design of equipments has been important, and this is particularly related to duodenoscopes. And there have been a number of reports in literature which have identified the faulty design of the duodenoscope, particularly the elevator channels, that are not amenable to proper cleaning, to be related to carbapenem resistant organisms getting transmitted horizontally between patients. So if you see, cleaning remains an important step even before any kind of sterilization and disinfection is taken up. Again, here you see a variety of organisms, and same processes or reasons for contamination or lapses are responsible. Viruses, again, the same thing, either devices or the process of cleaning, sterilization, and disinfection not done appropriately. This is to do with ERCPs, and here again, as you see, it could be water. Even an automated endoscope reprocessor, if it is not correctly cleaned, is going to be a source of infection for the next patient. And similarly for even bronchoscopes, where a whole lot of non-tuberculous mycobacteria can come both as infection as well as pseudo infection. So in the microbiology lab, we need to be very careful when you see a series of maybe smear microscopies that have acid-fast bacilli coming from your bronchoscopy suites. moving on to another very good paper that I thought was by S.J. Dancer in the Journal of Hospital Infection, surgical site infections linked to contaminated instruments, and they investigated an outbreak in an orthopedic unit and the ophthalmology unit, and they found that packs not drying, and this is again something which Mr. Ujjwal also pointed out could be one of the KPIs, and a whole lot of organisms, corns, even bacillus for that matter, coming out of these sterile packages when they were cultured were found to be important reasons, or could have been the sources of contamination, as a result of which SSIs happened. Another article from Hong Kong where this was basically in a dental clinic, and here again they had a failed sterilization episode which they investigated, and this was a rare lapse in monitoring during the autoclaving cycle is what they said. And at the moment they identified it, apart from the on-site investigation they conducted, they also put in a way to risk assess and test all the patients who had undergone procedures for testing for BBVs. They put in post-exposure prophylaxis measures for Hep B, hyperimmune globulin to Hep B, tetanus toxoid, and they followed up patients for almost 6 months. I think there were two patients in this group that were investigated who had a bloodborne infection. But the immediate recommendations that this paper makes is that dating of instrument packages, signing of all documentation that comes out of the all printouts that come out of the autoclave, color change of the chemical indicators with each load, and daily autoclave performance needs to be noted and signed down by the sterile services personnel or supervisor on a daily basis, and needs to be implemented immediately is what they recommended out of that outbreak investigation. So this was another outbreak coming from Oregon, USA, on non-tuberculous mycobacteria in joint prosthesis. Here there were 9 patients who had undergone hip or knee prosthesis and grew non-tuberculous mycobacteria. In fact, this was very interesting because they, apart from the environmental surfaces, they also found the hand of one of the vendors who was bringing loaner equipments into the hospital to be colonized with M. fortuitum. And they actually suggested a chlorine bath for this particular vendor. So, loaning equipments for prosthesis, joint surgeries is something which is very common to all of us. And this paper suggested that this process needs to be looked into very carefully, and before using any kind of loaner equipments, and understanding how these vendors handle it. Each institution should have its own protocol to ensure that these instruments are appropriately sterilized before they are used on patients. Closer to home, basically, we have indirect reports actually of suggesting that there could be lapses, and here is a paper on surgical site infections due to NTMs and under-recognized and a mixed diagnosed entity coming from a team in down south. I think it was Apollo Chennai who reported this, and another one from East Tata Medical Center, which looked at why should there be wet packs in steam sterilization and its consequences. So I found almost no reports really of direct evidence to investigation of outbreaks, and we all understand the reason why this could be, but certainly indirect reports are there. And in fact, I'm sure all of us have come across discussions where we've talked about non-tuberculous mycobacteria causing infections in minimal access procedures. I even heard about non-tuberculous mycobacteria causing infections in hair transplant and such procedures. So what are the reasons for the non-compliance? Again, coming out from the JCI document, they said lack of knowledge or training in proper sterilization techniques, or lack of HLD equipment, lack of access to evidence-based guidelines, no oversight by leadership, low priority assigned to sterilization and HLD of equipment, and a lack of culture of safety that supports the reporting of safety risks could be responsible for these non-compliances that occur at CSSD level. So how do we really overcome these issues? And someone mentioned earlier, I think it was Mr. Ujjwal, about competency assessment. So training, retraining, and competency assessment is something which is very, very important to the team who handles this area. Manufacturers' recommendations are always there, but are they really available to staff? Ensure that these are available to people who are on the ground. Follow current evidence-based practice guidelines, monitor compliance to standard practices, report lapses in a non-biased manner. I think if we point fingers to people who report lapses will never get reported. So have a measure in which, or have a process in which lapses are reported and they are investigated in a very non-biased manner, non-punitive manner. Conduct regular audits to identify non-compliances. And also, audits play a very important role in identifying local challenges that might actually be on the ground. Nobody does, or nobody wants to create a lapse because on a deliberate purpose. So there could be some ground level challenges that need to be dealt with, and leadership should support best practices. So so many times we hear of endoscopy units wanting to cut short the time of HLD by 5 minutes because the doctor is pressurizing them. So I think it is up to the leadership to support that optimum time and concentration should be given to such processes. So finally, to summarize, sterile supply lapses are a global phenomenon. The extent of problem varies, and certainly in India, it is grossly reported. This impacts the patient in terms of infections that happen, length of stay, costs, etc., and also the healthcare. We are exposed to litigations and bad publicity. And finally, leadership needs to assign the highest priority to sterile supply processes. So with that, I'd like you all to thank for your patient hearing.
Thank you, Aruna. I think that is the most important thing, that CSSD needs the highest priority. And thank you so much for showing that we all have problems across the globe. If we don't have publications from India, there are reasons to it which you have pointed out, but I'm sure we all do have problems which we can sort out for sure. Moving on to the next lecture, may I please invite Mrs. Gauri Bhatia, who is a freelancing trainer and consultant. She has a huge experience at Hinduja Hospital and Lilavati Hospital. In fact, she's the leader as far as CSSD is concerned, and has been a good trainer, a good orator. Welcome, Mrs. Gauri Bhatia.
Thank you, Dr. Shweta. I thank all the organizers of HISMF for giving me this opportunity. And I also thank Dr. Geeta Natarajan for refreshing our old memories. I'm really privileged to having worked with all of them who set the ball rolling in way back 3 decades back, when we were only trying to standardize the practices in CSSD. I was also a part of the first handbook that 3M had helped to publish in-house as our national best practices for CSSD. So I go on with my topic, the importance of pre and post sterilization activities. So I also once again thank the organizers for very thoughtfully giving me this subject. And I will once again, just with your kind permission, read this, the importance of pre-sterilization and post-sterilization activities in and beyond CSSD. So the key words are pre-sterilization, post-sterilization, and in and beyond CSSD. So, and I'm really thankful to Dr. Aruna to open our eyes that what we feel that we are doing in CSSD, whether everything what's done in the CSSD or with the help of CSSD people in the other departments, whether it is actually leading to the outcomes. Before starting my presentation, I would like to remind everybody that the definition of sterilization itself says that it's the probability. Probability means the possibility of achieving the outcomes. So when we talk about probability and when we talk about possibility, every activity that's in the cycle, all the speakers before me have already shared the CSSD cycle. So we need to pay our attention to every activity in the cycle, whether that is complying to the best practices. I just love the statement that Dr. Aruna Pujari's presentation had. Leadership should support the practice of best practices. This is what every person in the CSSD has to understand, and especially the supervisors and HODs have to make sure that we make them understand why are they doing it and how should they do it, and if not done in that way, what will be the implication on the patient care. So let's discuss about pre-sterilization, what are the activities, and I will start with beyond CSSD. Beyond CSSD means it starts exactly where the material is used. So this is, I'm calling it as a user department for the ease of understanding. As soon as the material comes out from the patient's body cavity, this is, I'm talking about the critical items which are coming to CSSD for sterilization, but it holds true for all the items, whether it is non-critical, semi-critical or critical. Cleaning is the first step, which we have to do it as it is recommended by the manufacturer. So wiping with the wet mops, flushing, if it's a lumen, it needs to be flushed immediately. If we have a provision of washing sink very close to our procedure, or whether in the dirty utility area, we used to rinse it under running tap water, or at least we have to keep it wet. We do get the sprays nowadays. We do get the mops, which are the mops which are having the enzymatic, it's moistened with enzymatic cleaners or moistened mops. At least just cover that set with those moistened mop so that none of the muck, any body fluid, any organic, inorganic soil that gets dried on the instruments, then later on it makes it very, very difficult for cleaning. So this should be the practice that is taught to the person who is handling the instruments after clinician has finished using those instruments. The very important one more thing what is there is you have to check for the different parts. There are many complicated assemblies that are available now, as we already talked about the endoscopic procedures and dental procedures. Initially, the dental department was at the most doing filling and root canal. Now we have too many dental procedures. So there are many complicated instruments. These are not just single instruments. These are the assemblies. So first of all, the user department or the person who's assisting the clinician should know what are the different parts of this assembly, whether anything is damaged during procedure or it's damaged due to wear and tear effect. And if at all something that is not working, the drill bits, the scissors, the blades, the saw handle, the saw blades. So if at all anything that's not working will be known during the procedure. So all this needs to be communicated to CSSD. Of course, CSSD will also check, but it's always better that the communication goes to CSSD because some things are there which cannot be made out visually. Like some scissors may cut gauze piece, but it may not cut a suture. So it's better that we know about it and it's communicated to CSSD so that the quality can be maintained. And these things don't happen in the next procedure. Then you have to ensure the count because you have a checklist. Either you will have a physical copy of the checklist available with the set, or there will be a reference checklist either in the file or the soft copy will be available at the terminal where the instruments are being dispatched from. And this count has to be correct, because if at all any instrument remains in the user department, later on it makes a big problem for the CSSD to trace it. So we also need to understand over here one thing, that nobody does the mistake deliberately. We all know about it because we have also worked and we know actually burden people with complications or with communication related issues. More they focus on their technical part. So ensuring the count as per the checklist is another prerequisite where you can reduce a lot of other communication issues. putting it back in the container at the designated receptacle. This is very, very important. There are very delicate parts, especially in the scope, minimum invasive surgery procedures. There are tips, there are screws, there are handles. So all these things, nowadays, we are very lucky that we get those graphic containers, especially in the orthopedic joint replacement surgeries, especially the loaner instruments, because everybody cannot know all the instrument sets. But then this has made our life very, very easy, that every component in the set has a particular place allocated to it. And the user also has to send the instruments as per that, and it becomes it becomes very easy to even count whether all the parts of the particular assembly are available in that set or not. So it plays an important role. Then finally they have to make an entry in the exchange paper or on the online entering system, because again the error that may take place over here, it gets amplified as the cycle proceeds. Now we come to what are the pre-sterilization activities in CSST. We have already seen that there has to be a different decontamination area that's earmarked, and all the material, the used material, the contaminated material that's only given a pre-rinse has to be received in this particular area, because the technical staff, we also talked about competency. So the people who are working in this area are very well versed with what is to be done and when. So the moment it's the instrument tray arrives in this area, people know that they have to use PPEs. Then they have to know about the biomedical waste segregation, and then accordingly anything disposable that has come by mistake or any wrapper that has come by mistake also gets disposed of here. And then there are also safety instructions that are provided to this team. They know about sharp injury, they know about MSDS of the various chemicals that are used for decontamination purpose and cleaning agents, and then the first aid in case any accidental exposure was to happen. So post-exposure protocol is also there. So all these activities are very, very important, along with carrying out our day-to-day technical activities. Then we come to actual process of receiving the instruments. SOPs have to be important. Actually, points presentation, you can take it checklist for making SOPs. That is, whether we have included machine operation in it, whether the cleaning solution name is there, its concentration, the dilution is mentioned in the SOP, how to prepare that solution, what is the active life of that solution, what should be the replacement schedule, whether we have to label it on the tank, on the receptacle that's used for soaking certain instruments, till when is this solution active, when should it be replaced, use of cleaning aids like water jets, air jets, brushes, all these things are available there. And unless and until we write it down, unless and until we make it in the format which is doable, step 1, step 2, step 3, it's very difficult to expect a uniformity from all the team members, including dismantling and keeping it secured. Again, I'll come back to the, actually, Dr. Aruna's session was really an eye-opener, and I felt very sad about, like, we keep seeing that I have spent 3 decades in CSSD, I have achieved this, I have achieved that, my quality indicators say so, my sterilization assurance level is same, but what about the outcomes? Is any patient suffering from hospital-acquired infection due to any lacunae in the procedures? That's my ultimate achievement. So whether dismantling is another very, very important step, because unless and until you know the proper method of dismantling these complex assemblies, it will definitely not get cleaned. There will be some, and we know the size of microorganisms we are talking about. So we also know the size of microorganisms. Fluid, everything, do either a visual checking, or we have protein strips, we have ATP checks. All these are basically to validate our cleaning processes. We may not have a time for every instrument or every cleaning cycle for checking these indicators, but once our processes are validated and then we are following it to the T, and there is a uniformity in everybody's working practices, then we can definitely assure that we can achieve that SAL of 10⁻⁶. Then assembling assembling is very, very important. As I mentioned, that once we know what's the, like where which part has to be assembled and which part has to be kept open for the sterile access to all the of a particular assembly or a particular instrument, even that needs to be kept in mind. It's not that I opened it, but then I have fixed it in such a way that there is no steam passage to the sterilization. Tray may, your indicator might show a color change, but the problem is that the narrow lumen inside, which you have blocked with some screw by mistake, has not got sterilized. So that needs to be kept in mind. That is why we have a pictorial checklist now. We also take a training for the technicians who will be doing this work in presence of manufacturing company representatives who come for demonstration. And then people do understand which material is used and where all the body fluids can go and which part will touch critical organs. And so the assembling or at the same time keeping it open during sterilization is equally important. So sterilant permeability is something that has got to do with this keeping the material in open condition during sterilization, or the use of wrappers. Sometimes people become extra safe and they use extra wrappers, but they need to understand about whether the sterilant is penetrating up to the center of the tray with that extra wrapper also or not. Again, this also needs to be validated. What I would like to mention one point here. My dear colleague, Mr. Ujjwal, talked about KPIs, but I would say that the KPIs in a way are the checklist, because all the key performance indicators can come only on the points that need to be followed, because then only we can audit whether it was followed or it was not followed, or whether there was any gap or even difficulty. Sometimes we talk about gaps, but then we need to understand the root cause of these gaps. He did mention about RCAs also. So these are the difficulties in keeping those things, because there are many instances where especially these lonar instruments are overcrowded in a tray. So there was a regular practice that was followed, that we used to distribute it in 2 trays because we were not very sure whether all these will have a correct sterilant access, or probably it will create a lot of condensate at the end of the steam sterilization cycle, thus leading to a wet pack. So both these things were not acceptable from the sterilization best practices point of view. Packing, very, very important. We know what are the methods of packing. We know how to create a tortuous path so that there is no post-contamination of the sterile material. At the same time, we also know what is the right kind of packing so that the inner pack does not become over tight, especially in the linen packs, so that the steam cannot penetrate to the middlemost layer of the linen. Labeling, very, very important. If we do not label it correctly, if we do not follow a nomenclature, if we do not put a date of sterilization and date of expiry, there are again chances that there will be confusion. And whenever there is a confusion, there are chances of error. Indicators, we did see about something about the indicators. We probably might see in the subsequent presentations, but these are very important. And how to use, where to use, what are the different types, how to interpret the results, how to document the results, how to have a record keeping of these results. These are very, very important. If all this is taken care before issuing a sterile pack to the patient, we get the right outcomes, or what we are looking at is absolutely no reason for CSST to be the cause for the hospital-acquired infections. Loading, as we said, that if all the steps that are before this have gone correct, but if we have not loaded the material correctly, if I put a small delicate pack and on which I put a linen pack, it is pressed in such a way that there is no steam penetration, then I have, like, all the other steps have gone waste. So we need to understand how should be the proper loading. Then setting of sterilization parameters. There are many people who still keep asking me, Madam, what should be the drying time? Madam, how many pulses should be there? What should be the vacuum level? So all this will happen when we understand the principles of sterilization or principle of that particular process and the importance of all the phases of sterilization, importance of creating vacuum, importance of increasing the temperature with a positive steam pulse, importance of again creating vacuum, importance of the leak rate test in our sterilizer, what when the leak rate fails. So all this needs to be understood. We have to understand the theory behind all the processes, all the activities. Those are done in CSST, or probably those are done either in the user department, or we recommend others while handling the packs. We have to know a science behind it. And unless and until we know it, so there are many people who are very expert in doing the work, but then probably they lack the understanding of the procedure, or they lack the understanding of scientific principles on the basis of which these processes are dependent and why we do those things. So that is why training and corrections and retraining plays a very, very important role. So let's come to the post-sterilization part. In post-sterilization, definitely we will talk about CSST first, because sterilization happens in CSST. So CSST is the first department where post-sterilization steps after sterilizations will be followed. So the first and foremost thing, what I always tell my technicians, that you are not going to unload the material if you feel there is any problem in the sterility assurance protocol. Namely, if the printout shows that the process is not gone in a way it should have gone. Number two, whether your challenge pack indicator change has happened. Number three, whether the indicator on each and every pack is showing a color change. Then you unload the material. After unloading, a very, very important step is cooling. Why? Because our sterile storage area is air conditioned and the sterilizer is at 134 degrees centigrade. The moment you open the door, it's not a magic that both these areas will become at the same temperature. So definitely there's going to be a condensate under especially the bulky linen packs. So if you just leave them at least for 10 minutes on the trolleys, especially in emergency, or especially when somebody else is wanting to go off duty and wants to put a delicate instrument on the trolley, he normally tells the technician that you immediately unload it and give that carriage back to me. So all these things have to be understood, and the supervisors, over a period of time, supervisors even start understanding the psychology of the people who are working with them. So the schooling period is something which cannot be done away with it, how much ever emergency we are in. If we handle the hot pack, there are chances that we will drop the pack. So the schooling is very important. That's why I have included it in my presentation. Then the storage. Storage will be at the appropriate rack that is designated for a particular pack. And then when we are storing, we also have to think about the environment under which these sterile material is stored. So maintenance of clean room parameters that are in the sterile storage area. Location and labeling of racks is very important. Again, if you misplace these sterile packs, there are chances that people will keep on searching, and in order to search, they will look at all the labels. So more you handle, we all know about the event related sterility versus time related sterility. I'll just mention one statement about it, that nothing happens to the sterile pack when it is just kept in the clean environment at its designated place, even if it has passed its expiry date. Because we all know that organisms do not just come out of nowhere and sit on that pack exactly after 7 days after 12 midnight. So what happens, what actually creates a contamination is our handling. So the events that happen after sterilization are the events they are compromising with the sterility. So if we do not have a labeling of the racks, if we do not have FIFO that is followed for the arrangement, I will again share one small example that nursing in particular department, in every shift, can you imagine that thrice a day in every shift they used to hand over sterile material, like in order to attach an accountability कि मेरी shift में ये गुम नहीं हुआ, आपकी shift में गुम हुआ है, वो लोग गिन लेते थे और physically they used to touch those packs and they used to count. So I stopped this practice. I said, you cannot do this. you have to have a place where the label is visible. You can look at it that there are 3 trays in that particular set. So there are 3 dressing sets. You don't have to touch it. You don't have to take it out from the rack. You don't have to replace it on the rack. And in between, if somebody calls them, then all the packs remain as they were while counting. So all these things also have to be taken care of. Like it also matters. Asepsis, what do we call it as asepsis? Asepsis is something that after sterilization, when anybody is handling a sterile pack, the person has to follow practices. And all needs to be understood by every team member in that cycle who is instrumental in getting this sterile pack to the bedside up to its use. Similarly, transport, it's very, very important that the transport of the sterile packs happens in the closed trolley. They follow a specific path that is given to them. They especially use the lift that is allotted for the sterile material distribution. They go and place it on the designated place in the clean utility area or wherever means in the clean environment in the dressing room. It's designed to store the sterile material. And the issues after transport, the issues when the person, our CSST person is going, he is the first role model who will be teaching others that how to handle sterile material, and that is the way we expect everybody to handle sterile material till it is used on the patient. Now we come to beyond CSST, that closed trolleys are important because there are certain departments who collect their own material at the time when they need it. So they also have to have the trolleys. They have to make sure that those trolleys are disinfected. Those trolleys are not used for any other dirty purpose. So this is very important on the surface where the sterile material is kept. Training for handling of sterile material, very, very important, right from the person who's collecting it from CSST to his placing on the rack and the nurses who are assisting for the procedure, to the doctors who are actually using it for the procedure. So everybody has to know about the importance of hand washing, has to know about how to handle, on which surface it is to be kept, how to open the outer pack, who will handle the inner pack, who will handle the sterile material, how to open that container even. Sometimes the containers have different locking mechanism, how to open that container, and then there are different packs for these complicated assemblies that where the tips are kept. That is why training plays a very, very important role in all these steps that are used for taking the sterile material from CSST up to the usage on the patient. Transport route, dumbwaiters, lifts, timings, all these are again very important while setting up a protocol. As I rightly said, that unless and until we have protocols, we have systems in place, we just cannot sit back and wish that everything will happen as we are expecting it to happen. We will have to write it down. We will have to verbally commit.
Can I ask a question?
Yes, please.
Yeah. Dr. Shaheen here from SRCC Children's Hospital. In the ICUs, we've got trays, stainless steel trays, which in which the injection syringes are kept. Is it necessary to autoclave them? Is my question. Should it be autoclaved? Because will anybody answer this question?
I think Ujjwal is a CSSD expert. He should take it.
Mr. Ujjwal Chakraborty, are you there?
Yeah, I am there. So just to answer it, those trays are called as knife dish or some closed trays. Those trays, there is no need to sterilize. Hope I am audible, right?
I got it.
Yeah. There is no need for sterilization of keeping your instrument or your injection syringes inside the tray. So only thing is that tray needs to be cleaned properly. That's it. No need for any sterilization. Because
Yes.
anyway, we are not expected to have unclean or contaminated trays. So those trays has to be cleaned properly. But as far as the sterilization is concerned, no need.
Yes, Usual to add on to it, this is Netra Vaidya. To add on to it, one more thing which, basically the tray is kept over there for quite a long period, for about 8 hours or so. So the cleanliness is more important than sterilization. If you assure the cleanliness, because you keep on changing your injections and syringes, so you keep on handling that. And especially when it is ICU, you are more particular about, the patient is immunocompromised and then you have to take care of the patient. So under the circumstances, people feel sterilization is 100 times better. Yes, of course, no doubt about it. But once you open it over in an atmosphere where there is no sterility maintenance as such, majorly, the air and all is not 100% sterile. So then you have a query to, kind of ask yourself that the frequency of cleaning is important than the sterility. So it's the organization's call. I would say that way.
So if I may add to this, Shaheen, meaning we will be in a false sense of security if you say you sterilize and then everything is fine. So even sterilization remains only for a particular period of time. In fact, I came across an article where they showed that inside the OT also, if you keep sterilized items open, that is during the procedure also, they tend to get contaminated.
So I'll just repeat the points on this post-sterilization activities beyond CSSD. I was explaining that how the trolleys, even the trolleys that are used for transporting the sterile material are important.
This slide was done. We could hear till this. Probably you can go to the next slide.
Training for handling of sterile material?
Yes, all done.
Yeah. And transport route, dumbwaiters, lifts, timings.
Yes, done.
Storage at user department.
Yes.
Location, open racks, maintenance of area.
All of it.
Yeah. Aseptic handling and application training.
Done.
Yeah, this was my last slide. So I would conclude by saying that if we have SOPs in place, if we have all the training with the reasoning behind all the activities, why are they required, and sterility assurance and sterility maintenance is not only putting the material through the sterilizer, it's the combination of all these activities, those are mentioned over here, pre and post sterilization in and beyond CSSD, then only we can ensure that the sterile material reaches to its point of application. Thank you very much.
Thank you, Mrs. Gauri. I think your practical experience of so many years have really enlightened people, because you spoke about the points which are very, very practical and people should put in their practices. So thank you very much for that. The next topic is by Dr. Geeta ma'am, and she has been teacher to all of us and needs no introduction, and I would be not in a position to give the introduction also. However, I must mention here that she's been chairperson for HISMF for some time, and the activities have been really boosted. They're contemporary and very practical for a long amount of time, and it is because of her. And the last thing that I want to tell about ma'am is that when you talk to her, you are amazed by her knowledge. The amount of nuances that she knows about microbiology are phenomenal, but you are also amazed by her lateral thinking, and that is the topic today. Ma'am, over to you.
Thank you, Shweta. As usual, you always provide a wonderful introduction, and I do not know whether that is motivation enough to speak on what I have said that I would. But then I have made a small attempt to do the same. So, I thought, why did I choose this topic to present? I didn't think that I would be the only, or we would be as an institute, the only institute participating in something like how to work without a CSSD, and is it possible to work without CSSD in today's scenario? But considering that there is nobody else who is opting, and having listened to the previous speakers with their wonderful content and their vocabulary, verbal diction, the way they communicated verbally. That's what I mean. So it probably does not give any room to doubt the fact that there is a need for CSSD, but it's not just about having a CSSD, right? So a CSSD is something that's central. A CSSD is a service unit of the hospital. It is currently a requirement by the National Medical Commission. So even if we are a medical college, we are supposed to be having a concept and an infrastructure for a CSSD. Area where Gauri also pointed out, the previous speakers also pointed out, Lona also pointed out, things are received which have been used already on a patient. Those are processed so that they become reusable in terms of infection prevention, in terms of sterility, or in terms of high level disinfection. And then what probably does not get included in this definition is how long you can go on reusing the same thing. So that's something that people need to look into, like even if it is a metal instrument, for how many years can I go on reusing that same instrument? So we are looking at physical integrity. So is physical integrity always a visible phenomenon? Nobody knows. Then it is a place from where all the departments in the hospital need to be supplied with sterile items all the time. It could be any time of the day because we have emergency surgeries going on. And finally, the most important aspect of a CSSD is the role that it plays, or what is the objective of a CSSD is to provide patient safety. Okay, so whatever we use on a patient is not going to add to the infection hazard. So I think somebody earlier pointed out, I can't exactly recollect who did it, but the quality supply, I think Lona mentioned about this, quality supply of sterilized items in different settings in the hospitals. So it's a centralized processing area. Now a brief thing about what we are at KEM, and this is there on the website, and some of you, or almost all of you who are from Mumbai, have visited KEM at some point in time. It's an institute that's going to be completing its 100 years in 1926, or entering the 100th year in 1925, as they say. It has a huge student population of 2,000, of which I think about 500 or more are postgraduate students. These are our statistics, and these are the statistics of 2021, when half the services were disrupted. So we can say that 40% of the services were disrupted in 20%, and therefore the numbers we are looking at are actually 40% during of what usually happens in a regular year. So that's the OPD attendance, IPD attendance, and when we concentrate on the number of surgeries, and the procedures that we do, it's a big number. It's a big number. And then we have actually 12 operating departments which are situated along multiple shores over an area of approximately 20 acres. So considering all this, there is no concept of a central sterile services department, because it is impossible to, because it's not just about sterilizing something and giving, it's about receiving something, walking through all those things to receiving area, going through the sterilization process and taking it back to the area. So there's a lot of manpower that will be involved. There can be errors that can happen, like Gauri was pointing out, during all these situations. Though we have, for the sake of saying it, for procedures, we have a central area for sterilizing the procedure trays, because procedure trays are multiple. You can have a tray for one day and you can make tray for another day, and those can wait. But sometimes in the OT, you need some things immediately, and we can't be waiting for a long period of time for supplies to be received from the CSSD. So we call this unit, which is above the blood bank, it's actually a pharmacy unit. And we consider that as an area which is supplying to us what are called as central sterile services, but that is catering only to procedure trays. So what do we have? We have peripheral departmental units. In every operation theater, you will find one. In peripheral, some of the peripheral ICUs and wards, you will find one. Especially, you will find one in the cath lab, where there is infrastructure that is required for pre-sterilization and post, where there is equipment and when there is manpower. So what is the role of KMHSC? We are all, I think those who are attending, most of us today, are all members of some form of an infection control committee, or at least have an interest in infection prevention and control. So our role as KMHIC is to provide the awareness and the initial training that would be required. And over a period of time, what I have realized, it's not just about a single training. Okay, so like Aruna said in her presentation, there is retraining that is required. So by the time you reach that retraining, there is another lot of people who have been deputed for that particular unit. So it becomes another training. And most importantly, what I do want to mention here and is that the trainers who go for these training sessions also need to be updated about what are the current technologies, what are the current recommendations, what are the current specifications, and what are the current practices. So unless the trainers who train are to updated, the things will remain the same as they were happening in 1930s. The role of microbiology is only to just give me a second. Yeah, the role of microbiology here, I would consider it should primarily be restricted to monitoring the activities of the Central Sterile Services Department. And in KEM, the OT sister in charge is overall in charge of the OT as well as the head of the department or the head of the unit who is operating on that particular day assumes overall responsibility for the activities that take place in terms of their sterilization processes. So considering this situation, how do we monitor? So since I come from the microbiology department, I'm a part of KEMHIC and I love infection prevention and control. I've been in it for so many years that, it's time for me to probably fade out a little bit. So the current practice is primarily to have checklists, because checklists, by using a checklist, we forget nothing. Hopefully, if we know and we are updated, by using a checklist, we are able to record the things that need to be recorded. Don't make a checklist which is impractical to use. Okay, if you have 120 points, like I have seen some checklists, you will never ever be completing that checklist ever. So it's important to know what needs to be included in the checklist and use only those that need to be included and monitored. So what should be at a minimum be included? Records of sterilization cycles and the sterilizers themselves, record of sterilizer maintenance and calibration. So this is something that is a little dicey. I do not know about the institutes. I can speak only about my institute. I know that all the sterilizers, there is a maintenance program which has been now outsourced, but the calibration program is not something that is well defined. So I have to keep sending reminders that this is due for calibration, get them calibrated. Then what do we monitor? We also monitor the use of biological indicators. So when we started off with this program, maybe about 10 or 12 years back, the monitoring the sterile services units in the multiple departments, apart from the chemical and physical and all other indicators, we got on to using the biological indicators. So initially for almost a week or a month, we were using them on a daily basis, not all the cycles, but any one cycle of the day, we would use it in the way that Gauri mentioned that they need to be used. Almost always that's what was told to them. So we hope that that's what they did, because that's not something that we are monitoring. So from there on, we moved from daily, then we moved on to doing it weekly. And some of the units perform so well that we are doing it monthly, and wherever it is indicated, whenever it is indicated, like if it is an implant, you do it for every implant cycle. But otherwise, it is usually a weekly thing that happens in all the OTs. However, all other parameters are monitored and recorded. We have currently we have two types of sterilization systems that we use. One is the steam sterilizers, popularly known in my hospital as an autoclave. If you say it's a steam sterilizer, they may not recognize it. And the other one is ETO. So ETO is available in the pharmacy department and certain other peripheral departments. We also have started off with the water quality testing, and this is a point that was brought to my attention, I would say our attention, in one of the previous meetings of HISMF, when the quality of water was discussed at length. And this was initiated by, I think, Rohini to a certain extent, and we considered it as something that is useful to be monitored, and we do monitor the water quality that units in our hospital, like pediatric surgery, for example, or the obstetric and gynec department, which have a regular record of patients who get infected following surgery. And then we have zero tolerance. In terms of sterilization, at least I can say that KEM has a policy of zero tolerance to any deviation in sterilization period. If your sterilizer is not working, there is no which way the microbiology or the HIC is going to say, it's okay, chalega, aap kar lo ek do, koi problem nahi hai. No. They run it once more again, and if fails, it's called as a failure. And if you have a definition of failure being ascertained, then you cannot by any means of or any stretch of imagination try and use it surreptitiously or any other way. So there is a zero tolerance policy to deviation in sterilization, in which case I should have a policy, or we should have a policy rather, I'm sorry, for eventual breakdown. So if the sterilizer in say X department breaks down, what do they do? Okay. So in this situation, what we do is the Central Sterile Services Department, what we call as the pharmacy department, that is catering initially or right now to procedural trays, takes care of the additional load and work it up for them. So that's how it is working now. So what are the challenges that we are facing? I've kept this presentation short because the whole essence of this thing is we know what is CSSD. At least we assume that we know what is CSSD. We know how a good CSSD needs to work, and we know what could be the areas of concern. So we look at all these things and see how best to operate the current sterile services department, right? So what are the challenges that we face during these activities? One is because of the there is definitely a policy of staff rotation, which includes what we call as the brothers. They are called as brothers, and then we have the staff nurses who are appointed to the OTs, and we also have the OT sister in charge. They all have a rotation program, right? So it is important that we continue to maintain and motivate their awareness and training in terms of what needs to be done. There is no shortcut to this. To answer that question, are we doing it? No, we are not doing it all the time. It sometimes becomes impossible to do it all the time, but we try to chip in, or we try to tell the previous group that was already there to pass on what is required to the next group. Because when you're talking about rotation, they are not rotating from one OT to the other. They may come from ward, they may come from any other area, they may come from OPD, and they will straight be there in the OT. So we have suggested that those who are posted to OTs and ICU should first undergo the training and be posted, but that's yet to see the light of day. Then there should be the challenges that we face in the regular. See, there are two types of indicators for any activity that we do in terms of infection prevention and control, or that's the way I'm looking at it. There are something called as process indicators. What is the sterilization process that is happening before sterilization, during sterilization, and after sterilization? And there are also outcome indicators. So both these need to be audited. Okay, so are we in a position to audit all this? Not at all. The only thing that we are auditing all the time is the sterilization cycle. Whether the packaging before sterilization cycle, the cleaning, the disassembly, the assembly, and then whether after the sterilization cycle, the maintenance of the packaging, the storage, that's something that you can visually inspect while you go for an audit to the physical audit, but that's not done every time. So regular monitoring of the outcome indicators probably is the only measure that we have to find out if things are in place. Those things may not be in place, and then the effect of that something not being in place is seen much later. Okay. So I don't know whether I should say fortunately or unfortunately, but I know for sure that we have not had a major outbreak of surgical site infections. It's not as though we have never ever had an outbreak. In the past, we have had clusters of cases because of certain types of organisms, but you trace it to a practice that is not directly related to the sterilization procedure itself, whether pre or post, but it is related to the practice. So I do not want to relate it to a sterilization mechanism, and therefore I have not considered them as outbreaks related to sterilization. Then there is also this dependency on microbiology. I don't know, all of us want to seem important, right? But after a period of time, we need to understand that we are not experts in everything. So if you have a sterilizer that just conks off, okay, so you need to have a temperature that's maintained at 121 or 134, depending on the type of sterilizer that you're using. It doesn't maintain that temperature, and then they call you what we should do. So who should be called? It should be the engineer who should be called. So there is, I don't know how you work. It should not be routed through the microbiology. So everybody who is part of the supply of sterilization should be a part of this central sterile supply department, something like a committee for central sterile services. And these services then each individual can be identified based on their roles and responsibilities. If there is problem with the sterilizer, who should you look up to? There is a failure of biological indicator, that means something is not being maintained for the for the period of it's very easy to say, do use a process indicator, use classify indicator, use integrated integrators. But for a public hospital to spend so much on these kinds of indicators is absolutely not possible. So there should be a mechanism, there should be someone else to be dependent on, or it should be dependent on a committee, and each person in that committee should have a role to play. Calibration of equipment is a concept that the institute is slowly, picking up. Calibration of equipment is something most of us work in microbiology laboratories. Almost all of us, I think, are accredited by some accrediting agency or the other, and therefore we understand the importance of calibration of equipment. But for an organization like the Municipal Corporation of Greater Mumbai, calibration of simple equipment like autoclave is something that needed to be told and something that is yet to be practiced. So there are certain units which do on their own, but there is no provision for a uniform calibration as and when required, which is annually in case of autoclaves and ETOs that is happening as of now. And the other thing that we should consider, since I have been a part of the Hospital Infection Society Mumbai Forum, and for long we have been saying that we should come out with this, we should come out with that, and we should do this, and we should do that. So following this meeting, at least what I have in mind is we need to sit down. Whoever is considered as an expert, by we, I do not mean me. So prepare appropriate specifications for the items that are needed in a central sterile services department or a sterile services department, as I would like to call it. I'm doing away with the word central because it's not something that is applicable to KEM. So then we consider preparing appropriate specific. Nobody knows, even today, even if I call 4 or 5 people before sitting down to prepare specifications, I don't get a good feedback as to what should be the parts of that specification. Then you go to a company, a vendor who supplies a particular equipment, then they will only give you, madam, this is good, uska ye nahi hai, wo nahi hai, ye kharab hai, wo kharab hai. So as Hospital Infection Society Mumbai Forum, I think it is high time that we started with specifications for simple items which are required in the CSSD. I don't know how many of you would agree. And then some of you might say that Madam ko aur bhi kaam dena hai. It's not like that. I think it's the need. And all of us are in the dark about this. So finally, CSSD definitely is recommended, which is Central Sterile Services Department. But if feasibility does not permit, each peripheral unit that is there in that particular healthcare establishment should be considered as a CSSD for that unit. And therefore, everything that is to be done in a CSSD needs to be done in all these multiple units. And therefore, there will be multiple monitoring agents, multiple monitoring teams that would be required. It should have an appropriate infrastructure. There should be adequate and appropriate working equipment which are well calibrated. There should be trained and, more important than that, committed manpower who realize their responsibility is something not happening properly. There has to be a regular audit. And above all, like I think Aruna mentioned about this, there should be immense administrative support to do what we want to do. Because it's after a long talk multiple times with the higher authorities that the concept of calibration of equipment such as autoclave was initiated or is under initiation, I would say. So all these things are equally important, and all this is required simply because there is a culture of safety that needs to be established. Thank you very much.
Thank you, ma'am.
The third session, we have a very important talk on conventional sterilization methods. Of course, a very core responsibility. And I think it's extremely important to re-emphasize on the standard practices. So we have Dr. Malkit Singh address this aspect. Dr. Malkit Singh is the Director, Quality Management and Research, Alliance Foundation. He is a PhD medical microbiology from PGI. He has a lot of experience in infection control, in sterilization, disinfectants, in antimicrobial efficacy monitoring, and medical teaching. He has a lot of publications. He is an internal auditor for ISO 15189 as well as ISO 17025. He is also a chairman for medical lab studies in Punjab Technical University. and a chairperson on the National Expert Task Force for Medical Lab. So over to you, Dr. Malkit Singh. We are looking forward to listening.
Am I audible?
Yes, sir. Very well.
Very first, ma'am, thank you very much for giving me this opportunity to be a part of this webinar, prestigious webinar. And I have given a very basic and technical topic. Am I audible? Hello?
Yes, sir, you are audible.
So, as we all know that microbes are ubiquitous in nature and they are available everywhere in the atmosphere, hydrosphere, lithosphere. Some of them are beneficial to us and some cause infectious disease, and they may harm us from any of the environment, any type of environment. But today's talk will be limited to the healthcare environment. Hence, control over proliferation of these microbes become very important here. To control hospital-acquired infections, the removal of microbes from all the treatment areas and equipment is very, very important. We all know that prevention is better than cure. And in control of hospital-acquired infections, we use various procedures, including the including the sterilization, disinfection. In operation theaters and other important areas, many equipment are being used, and those are recycled after sterilization, and CSSD does this very, very important work. And sterilization is not only used for sterilization of the equipment, but it is also very, very important as per biomedical waste management rules. Sterilization is basically a process of freeing an article from all types of microbes and their spores. Previously, it was considered to be an absolute term, means theoretical term. Absolute means either the object is sterilized or object is not sterilized. There was no term partially sterilized. So nowadays, by the entering of new pathogenic organisms or other entities like prions, we are considering that any process which kills more than 10⁻⁶ organisms with a high degree resistant spores are that is the satisfactory sterilization process. Now I will be talking about the conventional methods of sterilization. Among the conventional methods of sterilization, heat sterilization, radiation sterilization, filtration sterilization are the most important, but normally organisms are being killed by the chemical methods also, but that is not covered in sterilization, that goes to disinfection. So we apply heat for sterilization of the equipment, particularly for those equipment or articles which are heat resistant. The articles which are heat loyal cannot be sterilized by heat. So this is a limitation of this methodology. It is most convenient, reliable, and applicable, and should always be used wherever it is possible. There are some terms like sterilization holding time, or in general we call it holding period. It is the exposure time at an effective temperature to ensure the complete sterilization. It has been derived from thermal death time, Bacillus styrothermophilus. No, but Bacillus styrothermophilus is a highly resistant spore, and it is even resistant more than Clostridium tetani. Next term commonly used is heat penetration time. It is the time taken by the load to attain required temperature. Then is thermal death time. It is the time to kill a specific bacterium at a specific temperature. Now, heat can be applied by major in two methodologies. One is dry heat methods, the methods which use dry heat, and the others are the methods which use moist heat. Dry heat kills the organism by oxidative destruction, means burning to ash. They are effective at high temperature like 150 to 170 degrees Celsius. And among these are red hot, like inoculation loops, tips, forceps, etc., which we directly insert into the flame and we make them red hot, so no organism can be there. Then secondly, flaming, we can sterilize glass bottle mouths, scalpels, needles, etc. by using flaming. And incinerator for biomedical waste management, it is very, very important equipment. All the soil waste are supposed to be incinerated. And nowadays, I would like to inform here that we are not having only incinerators which just burn the load, but nowadays the waste to energy concept has come. The heat energy produced from the incinerators that is being utilized for production of electrical energy in some advanced incinerators. Then hot air ovens are the chambers which provide heat, and these are used for glassware, non-sharp instruments, water impermeable oils, waxes, greases, and powders. The hot sterilizers, it is very, very important that we should ensure that it conforms to British standard 3421. It should have control thermostat and timer. That requires the calibration. The calibration is required biannual. The efficacy testing can also be done chemically by Brown's tube number 3. If we keep this tube, it turns from red to green if the sterilization is proper. And efficacy testing is also done by biological indicators. For hot air oven, Bacillus subtilis is used for efficacy testing. The holding periods for hot air oven, we can use 170 degrees Celsius for 30 minutes, then 160 degrees Celsius for 60 minutes, or 150 degrees Celsius for 150 minutes. Now coming to sterilization by moist heat. It kills the microbes by coagulation of their necessary proteins and enzymes. It is highly effective at 121 degrees Celsius, and the newly changed temperature is 134 to 138 degrees Celsius. Normally, we divide these sterilization by moist heat methods into 3 categories. One are below 100 degrees Celsius, others are at 100 degrees Celsius, and the third one is above 100 degrees Celsius. Below 100 degrees Celsius and 100 degrees Celsius, I don't consider that these are the actual sterilization methods, but they give us some sort of mechanical utilizable methods to make some of the products safe. Because these methods do not kill spores. Moist heat below 100 degree is based on a general concept that temperature of 56 degree for 1 hour kills vegetative bacteria but not spores. The most importantly used method under this category is pasteurization, which is done either at 63 degrees Celsius for 30 minutes or at 72 degrees Celsius for just 20 seconds. And both processes are followed by rapid cooling to 4 degrees Celsius. And vaccine baths are used to sterilize vaccines. These work at 60 degrees Celsius for 1 hour. Water disinfectors are used for linen and sanitary disinfection. These uses the heat treatment. Now, heat treatment includes hot water plus steam plus detergent plus washing action. It adequately kills vegetative bacteria. Time used is 3 minutes at 71 degrees Celsius or 1 minute at 80 degrees Celsius. For HIV and HBV contaminated equipment set, the instrument is to be set at 93 degrees Celsius for 10 minutes. But the washer disinfector has limitations that it is not suitable for porous items and hollow tubes that cannot be penetrated by water properly, and it cannot also be used for items too fragile to tolerate washing procedures. The moist heat at 100 degrees Celsius was first introduced by Robert Koch, father of medical bacteriology. Some people say father of bacteriology, and some people even say father of modern bacteriology. Anyway, the boiling and steaming at 100 degrees Celsius takes 5 minutes to kill vegetative bacteria, hepatitis B virus, and some spores, even but not the heat-resistant spores. for this. At that very time, Robert Koch developed Koch steamer. It is just like autoclave, but with an open lid, not with a pressurized steam. Third, the next method is the Tyndallization. It also works at 100 degrees Celsius. In this, day one, we sterilize the article at with the steam at 100 degrees Celsius for 1 hour. It kills the vegetative bacteria. And then it is followed by the incubation at 37 degrees Celsius for overnight. In this process, some of the spores germinate to vegetative. And on day 2, steaming is done at 100 degrees Celsius again for 1 hour. And those spores which were germinated to vegetative, those are killed. And again, it is subjected to the incubation at 37 degrees Celsius for the germination of some more spores. And day 3, the steam at 100 degrees Celsius again is given, and we consider that all bacteria are killed. Now we talk about the moist heat, which is also known as autoclaving. In moist heat is used most abundantly. The load is expected. The load is exposed to saturated steam at a pressure at an increased pressure, atmospheric pressure. It kills bacteria, viruses, fungi, spores, protozoa. But some transmissible agents like prons may, however, survive, like CJ and variants, then GSS syndrome agent. As a working principle in autoclave, the pure, dry, and saturated steam is pushed into the autoclave chamber. Now it condenses to water on cooler surfaces and gives 3 major effects: wet microbes, it wets microzoes, and it liberates latent heat, which kills microbes. Then significant condensation of steam attracts more and more steam into the chamber. The condensation of steam from 136 degrees Celsius releases 4 times more latent heat than from steam at 100 degrees Celsius. To understand autoclaves, or to refresh our knowledge about autoclaves, 2 basic types of autoclaves are being used. One is simple non-jacketed autoclave. It is made up of hollow tube with a thick wall stainless steel, but it does not have any other jacket, outside jacket. And in comparison to this, the double-walled jacketed gravity displacement autoclaves, they have a jacket outside the main loading chamber. So this jacket is first filled with the steam, and then the steam is released into the inner chamber. And that inner steam is released from the upper side into the chamber. If you can see this cursor, the steam is lighter and the air is heavier than steam. So air is pushed through the hole, which is at the lower level. Now, what happens in this, the advantage of this complex system is that as Madam Aruna Pujari and Madam Gauri Bhatia was discussing about the wetting of loads. Now, what happens if we use this simple autoclave? Definitely, we are getting the wet load, because we cannot dry inside the equipment. But here, if we are using double jacketed autoclave, we can dry the load even inside the chamber. Now, just after releasing the steam from the chamber, we open the lid, and at this time, the steam in the surrounding jacket is at 121 degrees Celsius or 134 degrees Celsius, as we have given. Because now, after opening the lid, what will happen? All the wet material will dry out. It needs just 15 minutes inside the chamber. That material will dry up because of the surrounding high temperature. Now, other types of autoclaves are there, like vacuum autoclaves. Among vacuum autoclaves, pre-vacuum autoclaves are there, multiple pulsing vacuums are there. In pre-vacuum autoclaves, in simpler autoclaves, we evacuate, we just push the air outside by with the help of steam. But here we go for pre-vacuum conditions. We create vacuum inside the autoclave and then give the steam. And in the second, multiple pulsing of the vacuum is given. Then we have multi-purpose laboratory microscopes. They assure us the complete air removal, drying, cooling, heating, and proper vacuum. For this, these equipment can be used for aqueous media, they can be used for sealed ampoules, or even for biomedical waste management, as they are microprocessor controlled and they have different programs in them. Then high security autoclaves are used for containment of 3 and 4 level bacteria or microbes. Then steam outlet is fitted with a filter. And these have double role. One side opens into the contaminated area, the second side opens into the sterile area. So the material is put from the contaminated area, from contaminated side, and is taken out into the sterile or aseptic area side. Then other autoclaves are using low temperature steam sterilizer, which is used at 73 degrees Celsius for 10 minutes, but multi-pulsing vacuum is used for air removal. So you can see some of the photographs, pressure cooker type, common laboratory autoclave, then vertical autoclaves, horizontal autoclaves, large autoclaves hospital, large automatic hospital, sorry. Now, while going for autoclaving, we need a special kind of steam. The properties of that steam should be that the steam should be saturated. It should be in free molecular balance with water from it is formed. Then it should be dry, means free of suspended droplets of condensed water. Then it should be pure, free of air and other non-condensable gases. Then heat should not be superheated. Now, efficacy of any sterilizer is very, very important. As I told you, in autoclave, we go for efficacy testing. And in hot air ovens. Now, in autoclaves, the efficacy testing can be done. And it is done by mainly, very simple is electronic and manual devices are there on the autoclave. We observe, we take their readings, observe and record them. And we know that if the pressure is not proper, if the temperature is not proper, then it means something is wrong. Then biological indicators can also be used. And for autoclaving, we use Bacillus stereothermophilus. 10 raised to power 6 or 6 spores are loaded in a strip, in a filter paper strip, which are commercially available also. Even indicator ampoules are available from some of the companies. Those ampoules can be used. And we see whether those spores are killed or not. So 2 spores are taken, 2 strips are taken. One is as control, positive control, and other is kept inside the load. After cycle completion, we take out both the strips and culture. If the test strip, which was kept inside the load, does not show any growth, and outside strip shows growth, then it means your autoclave is efficient. So bovitic test is also very, very important. It is used for sterilization of porous loads. It enables to ensure that air is properly removed from the sterilization chamber, and as a result, the porous load are fully penetrated with the steam. Now, these are some efficacy testing protocols, standard efficacy testing protocols, and these are mentioned in practical medical microbiology book by Mackey and McCartney. They say that for porous load containing wrapped articles, linen instruments, the temperature required holding period is 134 to 138 degrees Celsius for 3 minutes, and daily bovitic tests should be performed there, and quarterly validation of the rest of your thermocouple system. Then discard load 134 to 138 degrees Celsius for 3 minutes, and it should be compared with each master temperature record produced at the time of commissioning. So whenever we get the instrument commissioned at that time, the company engineers they give us master temperature record produced, and we should compare with that record. So efficacy testing is done. We were here. And for even hot air oven, 160 degrees Celsius, 120 minutes, and then 180 degrees Celsius is used for 30 minutes. And we should compare with the MTR. Weekly gauge check are required, and quarterly thermocouple validation is recommended. Then another thing is that gas sterilization is also used. It is exposure to steam at 263 mm of mercury at 73 degrees Celsius with large volumes of formalin gas. The new concept is the gas plasma. Gas plasma, basically plasma is a fourth state of matter after liquid, gas, and solid. So in this machine, the vacuum is created and hydrogen peroxide gas is pushed in the vacuum chamber, and then the activation is done by radio frequency or microwave, and then due to this activation, the free radicals are produced, which are mainly responsible to kill the microbes on the articles. Ethylene oxide stabilizers, ETO stabilizers are commonly used, but they have the advantages that ETO gases are toxic and explosive. Its sensitivity does not correlate with other methods. The vegetative bacteria dried in organic matter show more resistance than test spores. So the cleanliness has to be taken care into very strongly. Then material to aerator for longer periods after processing, so that the ethylene oxide gas is released from there. Now, sterilization can be done by filtration. The aqueous solutions that are heat-labile substances and cannot be sterilized by heat, they are passed through the filter of low porosity. We can see here that at this level, at this junction of these two funnels, flasks, the liquid is poured, and this junction has the membrane. From this membrane, the material goes down. Like here in the lower picture, we can see the filter paper with the pores, and the microbes are having more size than the pore size. So they remain on the upper side, and the sterile liquid goes downside. For this, the sterilizer filters are used in health sector to sterilize liquids that would be damaged by heat, like vaccines, antibiotics, anti-sera. Now, types of sterilization filters, as per application, there are a lot of types: membrane filters, syringe-driven filters, siege filters. These are asbestos filters. Then vacuum and inline filters. Then pressure filters, and then air filters. Air filters include HEPA filters and ULPA filters. HEPA full form is high efficiency particle arresters and ultra low particle arresters. The ultra low particle arresters are used in the fume hoods for fumes. Anyway, next are candle filters, which are commonly used in household water supply, the water for water decontamination. Lastly, we can use sterilization by radiations. Cold and hot radiations are used. Cold radiations are further divided into ionizing radiations, which are gamma radiations, and they are generally generated from radioactive cobalt-60, and commonly are used for sterilization of PET disposable plastics. And ultraviolet rays are non-ionizing radiations, and these are used at 250 to 260 nanometer wavelength and are produced from mercury vapor lamps. They are commonly used for sterilization of biosafety cabinets and for operation theaters. And lastly, I would like to talk about infrared. Some of the bigger CSSD departments, they are using hot radiation system, that is where infrared rays are generated, and these rays generate heat. The system has a moving conveyor belt which passes through a preheated tunnel using infrared rays to reach a temperature of 180 degrees Celsius for 7.5 minutes. And glassware and metallic instruments can be used and can be sterilized in it. It is it is used by CSSD method. Lastly, I have a message that sterilization is very, very important for healthcare services. There should be a well-written and displayed SOPs for each and every process of CSSD, not only sterilization process. No skipping of any step mentioned in the SOP be ensured. So training and retraining of the staff on each sterilization process should be ensured. Competency assessment of the staff should be mandatory. There is always a scope for improvement, and we should take care that everybody should be taken, feedbacks should be taken from everybody regarding improvements, and we always should try to improve our systems. Thank you very much.
Thank you,
Hello.
sir. Thank you, sir, for a very elaborate presentation on the conventional sterilization methods. It is very comprehensive, and I'm sure it's really given everybody a complete overview. We now move on with our next topic, following up with an equally relevant topic to sterilization is understanding the advancements in biological indicator technology. So our next speaker, Mrs. Ujjwala Pal, is going to be talking about the same. Ms. Ujjwala is the head clinical specialist India for OR and CSSD 3M. She holds MBA marketing from NMIMS. She has a postgraduate diploma in clinical research. She also herself is a practicing nurse, and she also has an infection control nursing certification course to her credit, and also she is an NABH internal auditor. Tons of additional activities that she has been working with. She has a couple of publications and a total teaching experience of about 15 years. So I'm welcoming Ujjwala Pal to deliver the lecture on the advancements in biological indicator technology. Over to you.
Thank you so much, Dr. Vidya, for such kind introduction. I'm really humbled to be part of such esteemed speakers. Thanks a lot, Dr. Geeta, Dr. Aruna, Dr. Shweta, for giving me opportunity to discuss about the advancements in BI technology. So while I proudly present this topic, because biological indicators is very, very close to us, 3M had been the first company to introduce BI in world, whether it is the self-contained biological indicator vials or a rapid readout technology. 3M had been the first company to introduce this technology. So we are very grateful to you for providing us this opportunity. So coming to, before we move to the advancements in BI technology, I'm just going to take a couple of slides explaining what this entire biological indicator technology is and its importance in CSSD. Okay. All right, so this slide, I think everybody would agree with me that biological indicator is nothing but a vial which contains a large number of viable microorganisms which are resistant to the sterilization process. The entire idea of placing biological indicators and the reason why it has achieved its gold standard in sterilization process is because it measures the lethality of your sterilization assurance practices. It really ensures that it is one indicator which is going to tell you whether your sterilization process is capable of killing the microorganisms or no. So if you would see, we have always seen that we can safely utilize biological indicators for our steam, ETO, as well as the plasma sterilizations. And there are two types of organisms that have been used. As already been discussed by our previous speakers, our biological indicators for steam will include the Geobacillus stereothermophilus spores, wherein for our ETO, it is the Bacillus atrophius. If you would see the entire process that how exactly biological indicator works, the BIs are basically put in a large number of populations. It's 10⁻⁶ population of spores which are present in a biological indicators along with the incubation media or a growth media. Both put together makes the biological indicator vial, and it ensures that if your sterilization process is fine, if it is capable of killing that high number of microorganisms, then it has been considered that if it can kill the organisms of 10 power raised to 6 microorganisms, then it will definitely kill the organisms present on our clean instruments. If you would see, we have moved from various types of biological indicators, and we have started from spore strip and gasoline envelope. You would agree with me that it took 7 days for the result to come. Followed by that, the self-contained BIs, which is the biological indicators. They have been introduced in 1970s. We have seen the result coming in 48 hours, which moved to 24 hours. And now the technology for biological indicator results is moved from 4 hours to 3 hours, and now to even get the results in 24 minutes. Now, why there's so much of importance given to this particular technology? I would just want to take you through a couple of more slides which are talking about the importance of biological indicators, what the guidelines says, and many of you have definitely have a couple of questions in terms of how exactly the biological indicators needs to be used and what is the guidelines recommendations. So I'm going to take you through that. Before that, let us just quickly understand that how do biological indicators do their job. So, in simple words, we can just say that the spores are exposed to the sterilization process, whether it is steam, ETO, or plasma. After you complete your cycle, the exposed spores, you basically remove the biological indicator out of your sterilizer. You will ensure that you're using the techniques to crush the biological indicator and you flick the indicator to ensure that the growth media is mixed. And if there are any spores which are still alive, they are basically going to be immersed into the recovery media or incubation media. And if they're viable, you get a positive biological indicator result. The entire, if you would see the graph here, Madam Gauri has rightly spoken about the sterilization assurance level. So SAL is something that we always want to achieve and want to make sure that our policies and procedures are so good that we ensure that we achieve a good sterilization assurance. Now, if you would see all the sterilization cycles, they're basically designed to kill the spores within the first half of a cycle. So ideally, the spores that are present in indicators should be inactivated in a half cycle. So that's how it should be. And by the end of full cycle, the spores should be completely destroyed. So that's the entire way how the biological indicators work. And because it has the ability to represent the lethality of the most resistant form of microbiological life. So if you would see, like for steam, we have Geobacillus stereothermophilus. Similarly, MEST 58, which is basically the guidelines for our plasma sterilization, also says that Geobacillus stereothermophilus is the only organism which provides the maximum resistance to the plasma process. And that's the reason it's the same organism which has been selected for steam as well as for plasma. So this presents the lethality of the most resistant form of microbiological life. And that's the reason it has its unique positioning of the gold standards. So if you want to understand what exactly the US FDA talks about the biological indicators, well, here it is. For steam, US FDA has clearly well established that you should have a biological indicator which has the type of Geobacillus stereothermophilus, the population. Now, most of the biological indicators that are present will always have a population 10 raised to 6. The minimum by US FDA is 1 into 10 raised to 5. So that's the population. Third factor which has been well established by US FDA for biological indicators is the D value. So D value is nothing but the time required to kill the 90% of spores at a particular temperature. So D value should be at least 1.5 minutes, when the Z value should be 10 degrees Celsius. And there are two more important aspects when it comes to biological indicators. So one is the kill time, second is the survival time. So you should have the longest kill time and the shortest survival time. So survival time, which has been established by US FDA, is at least 5 minutes. So that's what is for steam and also for EO. Wherein if you would see for plasma, while the technology of plasma sterilization is existing for more than 20 years now, but then the guidelines are still in a draft process, and we only have the type of organism that can be used for biological indicators has been established. So that's what the US FDA speaks about the biological indicators. As you know that for steam sterilization, there are so many guidelines which are talking about how frequently we should use the biological indicators. So I just thought that I'll just take out a complete screenshot of all the guidelines and show it to you. So if you would see, these are the basic guidelines that we follow. So there are many guidelines, like the guidelines in Japan, which basically talks about usage of BIs every load. I just want you to look into this particular aspect, wherein the biological indicators are talking about two aspects. One is the routine monitoring, second is the implants. While most of us are using for each and every load biological indicators in implants, for routine monitoring, please see that your WHO, your MEST 79 guidelines, your AORN guidelines, your APSIC guidelines, as well as your CDC guidelines, they are suggesting to use the biological indicators at least weekly and preferably daily. We do have a WHO guideline 2016, which is stating that the biological indicators should be used once a day whenever we are using a multiple loads in your steam sterilization. So while we know that the usage of biological indicators is very well established for our ETO and the plasma sterilization, wherein for every load and every cycle, we have been using biological indicators. This is what the guidelines talk about when it comes to steam sterilization and how frequently you're supposed to use a biological indicators. Also, one interesting thing, if you would see, it also talks about BIPCD. While we see most of the corporate hospitals are following all the guidelines about the BIs, and we see many government organizations also ensuring that they follow how to place the biological indicators in the hospitals, in the sterilizers. But we do get the questions a lot of times from the nursing homes, from smaller hospital setups, that how do we place the biological indicators? So if you would follow ISO 11138, which is considered as almost a Bible for our biological indicators, it really talks about usage of a BI only and only in process challenge devices. These process challenge devices, whenever we are using for steam sterilization, could be as simple as creating your own 16 towel pack, or you could use the FDA approved packs. If you are using a process challenge device for ETO, so we cannot use biological indicator as it is as a vial in the sterilizer. It has to be in a process challenge device. So for steam, we can take 16 towels and create a pack out of it and put our steam sterilizer into the center of that 16 towel pack and put it in a sterilizer. Similarly, for ETO, since we cannot use a linen packs, we can use a simple syringe. We can put a biological indicator in the syringe and make it a point that it goes into our paper plastic pouch, and that becomes your PCD for EO. So this is how the biological indicators should be placed into our CSSDs. Now, how frequently we should get the results is what all about the advancements in the technology. And as I said, that while we have moved from 7 days of obtaining result for biological indicators to 48 hours to 24 hours, to now we are moving into getting the results within few minutes to few hours. Why exactly the requirement of it? While I really want to congratulate the organizers, and they have, how beautifully they have placed and showcased the global scenarios, the requirements, the basic requirements, and followed by the conventional sterilization methods, the topic of biological indicator, stressing that how and why the need for a right monitoring of a sterilization assurance really is going to help your hospital to protect themselves from any kind of issues, and also to prevent surgical site infections or prevent hospital acquired infections. So I'm going to quickly showcase this. Is if anybody wants to take a screenshot about the guidelines reference of vaporized. However, for all the biological indicators for hydrogen peroxides and ETO, the recommendation is every load. So why there is a requirement of advancements in BI monitoring? So as it was rightly said by Dr. Geeta as well, that root cause analysis, and Dr. Aruna, that root cause analysis of any process is very important. And it is not just about following SOP, but ensuring that we keep our eye on the outcome. So why there is really need for the advancements and why we should move from one specific types of biological monitoring to the advanced biological monitoring, the answer is all here. So at this moment, you would agree that there are very few, in most of the healthcare facilities, our sterilizer devices are seldom quarantined, and most of the time, before we get the biological indicator results, we are already, our instruments are out in the hospital. They're already been used by the hospitals, on our patients, and a lot of times the recall process itself becomes very, very complicated. If you would see the guidelines, recommendations, and how do we really ease out our entire recall process. And I know that the next session already by Mr. Tushar sir, he will be easing out the entire recall process for us. But if you would see all our guidelines, so MEST 79 and AORN guidelines says that if there's any positive biological indicator, all loads needs to be recalled since the last negative biological indicator. Now imagine that your last biological indicator is 1 week prior, then you really need to track entire week's load that has been shared and that has been already released from your CSSD. You need to track out the entire process. Sometimes the end result could be intimating your surgeons, intimating your patients, and issuing notice if the result of biological indicator is undetected and if there is any process in terms of a sterilization failure. So only to avoid this entire process of not, making sure that there are less instruments that are releasing from our CSSDs before the last negative result. So instead of waiting for entire 1 week, if the biological indicator frequency and the usage is happening on a daily basis, like how the guidelines are recommending, then the entire recall process can be minimized and we can really reduce the hospital-acquired infections. These are certain guidelines which are talking about how do we routinely release the non-implant loads. So if you would see, look at the last 4 points. We need to make sure that we evaluate all the data by an experienced, knowledgeable people in CSSD. We do not distribute load if any data suggests a sterilization failure. The recent guideline of MEST 79 2017 says that we need to ensure that we do not distribute the load if the data suggests a sterilization process failure, which means the failure of your physical monitor, your biological indicator, or any of a chemical indicator failures. Similarly, for routine load release of implants, the guidelines are clearly saying that the load should be quarantined until the result of BI testings are available, and we may use the type 5 integrating indicators in case of emergency to release the implants. So this is the guidelines which are talking about the routine load release of implants. So this really establishes the fact that why we should obtain the results of biological indicator at the earliest, so that we follow the guidelines, so that we follow that before we release the loads to the departments, we do have that peace of mind that the instruments that we are sharing with the hospitals, with the patients, with the departments are following all the protocols and are basically sterilized and are safe to use on our patients. So many of you have been using either a conventional biological indicators, or some of you are already using the rapid readout biological indicator technologies. We do have hospitals who have been using the technologies where you receive your EO results within 4 hours. We have hospitals where you receive a rapid readout technology results in 3 hours for steam sterilizers. And we also have hospitals receiving the results within 24 hours. So how exactly these faster results are achieved? So as Dr. Aruna said that yes, we must know that what exactly this technology is and what is the science behind it. So I just want to lay out this factor that when we are talking about the advancements in BI, so where exactly the advancement has happened. So just have a look at it. The conventional biological indicators gave us result within 48 hours. So all that had happened is every time that you're putting a biological indicator, now you know that you have to place it only in the PCD and in the specific areas of your sterilizer. When you're putting it post your sterilization cycle, you're supposed to remove it, crush the biological indicator so that the spore strip is getting immersed into the incubation or a great growth media. if there are any organisms which are present, the nutrients will allow the microorganisms to grow and multiply. Okay, and this is the process where basically if the spores are viable, if they're still alive, they're gonna have the nutrients, they're gonna release the acid waste. This acid waste, it's basically pH colored, and if the acid waste is released, it gets marked and you get a result within 24 to 48 hours stating that it's positive, and the dye basically turns into the yellow color. Now, how exactly you're getting the same result within 24 minutes or within 1 to 3 hours? So the entire game is into the technology and how do we really read these biological indicators. So if you would see, if the spores are alive, okay, basically the enzymes are breaking down the nutrients which are attached to a fluorescent dye. So you have a growth media and you have a glucoside in it, right? So the moment your spores start eating the if the spores are alive and when they're starting to eat the growth media, basically an enzyme has been released, which is earlier in a non-fluorescent form. Whenever it interacts with the growth media, you get a fluorescent release, which has been the enzyme which has been released, and it is fluorescent in nature. This activity is been detected by the auto reader, and this could be, and you get a result within 24 minutes. So basically, you get a results within same days, and sometimes when you're going for a super rapid readout technologies, you get a results before even your load is getting cooled. So the entire idea of how the technology is evolved is dependent on the media formulations. It is dependent on how fast we are identifying this technology through fluorescent signal presentation and identification. And what's the best part out of it is the technology is already present for last 10 years and is recognized by EMI guidelines. It is recognized by CDC guidelines, and it also has got a prestigious FDA certificates and the kite mark certificate available for the same. So this is the advanced technology. Do you need it, or why and how exactly it is going to help your hospitals? Well, the answer is all in this slide. So it basically is going to improve your overall turnover speed. It is going to ensure that your patient safety is given utmost importance and you're absolutely compliant to the guidelines. So now all the guidelines about the safety, about the recalls, about ensuring that you're not releasing the implant loads without the biological indicator results, everything is compliant when you're getting the results at a faster rate. Your OR metrics and staff satisfaction improves. It improves related to your start time accuracy, the durations. The best part of this is, while as rightly mentioned, that data is everything, and all of these technologies are completely digitally supported. You get to save your data of 1,000 data points in a system when you're going for technologies like super rapid biological indicators. If you're going for technology like the rapid readout technology, you can save the data of up to 100 biological indicator results, and it's completely automated, which becomes very easy to save, which becomes a good data points to store as well as for your audit purpose. If you would look at the cost, it really ensures that it reduces the dependency on the loaner sets, on the consignment sets. It really makes sure that it reduces the chances of overall hospital-acquired infections, thus overall reducing the cost of the hospitals. Your recalls are reduced, and overall your surgeon and patient satisfactions are also better, because when and even your satisfaction, I think what it really gives to the microbiology, to infection control and CSSD managers is the peace of mind knowing that the instrument that you're releasing is absolutely safe to use on patients. So that's the evolve or new technology in terms of biological indicators, where we have moved from the spore strips, from the technology which gave us result to 7 days, to the technology where we are receiving the results within 24 minutes. So all this information that I have been shared with you is as per the guidelines. And if any one of you require any support in terms of getting these guidelines from us, please write, or you can just write to us, and we will provide all the support and the requirements that you need. So that is all from my side. I once again thank each one of you to provide this opportunity, and if you have any questions, we'll be happy to take it. Thank you.
Thank you so much, Dr. Ujwala. This was really good. A very good update on biological indicators. So thanks a lot. Really appreciate your time. We move on to the next session. The next session is going to be taken by Dr. Shweta Shah herself. She's going to be speaking on high-level disinfection. So over to you, Shweta.
So, good afternoon, everyone. And I think it has been a very, very good, productive 2 hours. We are running a little behind our schedule. My presentation is short, and I will try to finish it as soon as possible, trying to save 5 minutes. But if you have any questions, you're most welcome at the end of this session. High-level disinfection, when we say, it is mostly for scopes, and it is slightly different than our sterilization units. So even if a high-level disinfection goes in sterilization process technically, many of our hospitals might not have endoscopy reprocessing unit in CSSD, and it might be next to the endoscopy suite itself. And that is how probably it makes it slightly different, because you might have this reprocessing of scopes at multiple places like ICU, and if you have two scopy suites like respiratory separate and GI separate in bigger institute, then you might have 2 separate places. So also many a times, especially the urologists, when they do cystoscopy, they like to reprocess the scope in their OT complex, and that is what makes it non-centralized process. And as Geeta madam said, that wherever you do the process, I think the technically all the processes should be followed in the same manner. The other thing that makes high-level disinfection very different is many a times your physician intensivist will ask you, why are you so bothered? Because it is not really going in sterile cavity. But I think Dr. Aruna has elaborately shown that it is a very, very crucial step, and it does lead to many of the outbreaks, and it has been pointed in literature. So both these things make HLD different. And let me try, oh my God. Yeah. So what is high-level disinfection versus sterilization? In simple terms, this is not complete definition, but in high-level disinfection, the spores will not be killed. The mycobacteria will be killed, because it will be according to the Spalding's classification. Will come to that. Aruna has already shown that. And in sterilization, nothing will be left. Spores will be killed. So high-level disinfection is a grade below the sterilization. Is high-level disinfection okay? That is the most important question when we say that there should not be any infection. So is it okay? It is upon Spalding's classification. When you're going in cavity with intact mucosal membrane, HLD is considered okay, because intact mucosa will provide some sort of barrier. There will be some local immunity, and sterilization is just not possible with these scopes. That is when you will go with HLD. If you have option of sterilization because the length of the scope is shorter, or it is compatible with the sterilization method, you will go ahead and do sterilization. You will not do HLD. HLD is a step down. So why HLD? Because you have your scope with multiple type of metal, glass, lens, rubber, which might not be compatible with your sterilization techniques. There are various pathogens Aruna has already spoken about, which are present, which are causing disease, and which can be present as opportunistic. But all this should be taken care by the HLD process, good enough if done properly. So let's go over some requirements. Now my presentation is not extremely comprehensive because I have that 15 minutes duration, and I've just tried to take more of FAQs, what we need to kind of definitely know. So what is the basic requirement of the area? It should be a separate ventilated room. It cannot be done inside the OT itself or inside the bedside, at the bedside of ICU. That is not accepted. Preferably a negative pressure room, that is a JCI requirement. And in a scopy suite where it is a proper HLD unit, it should be a unidirectional flow for sure, because you need to clean and then put in the disinfection. The air exchanges expected is 12 per hour minimum. It can be more. You definitely have to maintain the temperature and humidity. The process, most of us know this, and I'm going to go over one by one in very brief period. So pre-cleaning, this again has been eluded a lot of time, that it is very important that pre-cleaning is done, because no disinfectant is going to work if there is any bioburden or biofilm. So you can use cleaning enzymes, you follow the manufacturer's instruction, but pre-cleaning remains the most important step, and disinfectants work best in clean environment. That is what is the bottom line for the process. One has to do the leak testing, because if there is leak, external or channels, it's a complex instrument. Aruna did show a photograph. Leak test, if it's not working properly, there is going to be inadequate disinfection, also inadequate working, and it can cause further damage to the scope. Manual cleaning is important even if you're using automated reprocessors, because there is a compulsory cleaning required. That's a bottom line. I have been saying this probably for the third time. So flush all the channel, remove all the organic matter possible. If you have to use the brush, use the correct one as per recommendation, and don't forget to clean the brush themselves. Keep them dry, because water is one of the most important source of bacterial growth. Inspection should be done. So once you've cleaned it, you have to see that it is clean, not broken. Use lighted magnification, and this is one thing which I'm not very sure whether everybody does that. This gives you an additional reassurance, and that is what is important before you go for the disinfectant itself. Now there are various disinfectant available. Most of us started at some point with glutaraldehyde, which now most of us have shifted to OPA or orthophthaldehyde. The recent ones have been peracetic acid and hydrogen peroxide. Now, which one will you choose? One that it has to be approved by the regulatory body. You look at the accreditation or the chemical structure, whatever is approved, one should use that. You look at your scope versus compatibility of that particular thing. Preferably, it should be non-carcinogenic and non-corrosive. Each of these, glutaraldehyde, OPA or PA, have different shelf life and stability. So stability will include, one, before opening the can, there will be a expiry date. But once you open the can or dilute it or put in activator, look at the pH, the expiry date changes. Most of them will work for 14 days, some will work for more, some will work for less. But you need to know exactly what happens, and depending on that, you have to use the product. Like PA is less stable over the duration, a little more expensive, PA and H2O2 both rather. But you need to figure out that stability is all right for you or not, or the cost is all right for you or not. So also the cycle duration changes, and that is what makes the recent ones more useful. So depending upon your workload, you're going to decide how many minutes you have in between the two endoscopy procedure. So when you do use HLD or sterilization itself, it can be manual HLD or it could be automated reprocessing unit. But again, please note that the disinfectant, some are not for manual and some are not for automated. So you need to figure out with your manufacturer's instruction. So also look at the pH. And even if you have an AER, you have to have a good backup protocol in terms of manual disinfection. What is the most important when you talk about the disinfectant is MEC, minimum effective concentration. So as per the guidelines, every time you dip in a scope in the disinfectant, you should know that at this point the disinfectant is going to work. So for glutaraldehyde or OPA, the strips are available and most of us may not use it or use it once a day. But if you have a very high workload, you need to dip it every time, because at the middle of the day also it may stop working depending on your workload. And why will it stop working? Because the concentration gradually decreases because of the challenging load of either the organic matter or the microorganism that has come after your cleaning. So more cleaning, longer your disinfectant is going to last. So also you will rinse the water during the cleaning, rinse the endoscope with the water during the cleaning, and that water is going to dilute your disinfectant further. So that is how the HLD gets diluted. It also ages depending upon your use. Sometimes, so this basically decreases your MEC. And if you're topping off the chemical, that is not advisable, not recommended. But if you're doing that, that is going to create a lot of ruckus there. Also keep a note if the basin is not being clean, meaning you think that disinfectant is there in the basin is now clean or it is disinfected. That is not true, because the biofilm is going to, organic matter goes inside, so biofilm is going to form at the basin. So you actually need to clean your basin also. So every time you pour in a new disinfectant, before that your basin should be cleaned, dried, and then new one should go in. So once your endoscope is disinfected, how are you going to store it? One thing is very important, that you need to remove your disinfectant, because patients should not be exposed to any aldehyde or peracetic acid. It is not correct. Mucosa can get damaged. So multiple rinse are recommended sometimes by manufacturer. Also, there is some guideline on alcohol rinse, but you will have to figure out whether it is compatible or not and how are you going to manage that alcohol. The next thing is the drying has to be done. The water at the end of that rinse cycle has to be removed, and that is how your scope has to be hanged vertically. No coiling is recommended. So you have to have kind of a cabinet, because it cannot go back in the box, and the box in which the endoscope is received are never autoclaved. So you need to ensure that the scope doesn't go back in the same box. No coiling is accepted. When you hang it, because sometimes the scopes are very, very long, the tips should not touch bottom. The moment the tip touches the bottom, the water will remain in the scope and you will not know how much is there. And that is what is going to cause your bacteria to grow. So cabinets are very useful. Maintain the humidity, temperature, whatever, and the length of cabinet is extremely crucial. So that is how you dry and keep the scopes there. However, now horizontal storage is possible, but it is as per manufacturer's instruction, and those are separate storage cabinets. Water, madam has spoken about, Aruna has spoken about. Water rinse is the last rinse. So this is what will go in patient's body cavity. And if there are bacteria in the water, if the water is not good enough, the bacteria will remain on the surface of the scope. And if there are mycobacteria, they also will remain, because the environmental mycobacteria, the NTMs are always there in the water if it is not good quality water. Many of us use either point of care filter or RO planned. I'm sorry, I had made few changes of the spelling correction, but I think the presentation that I opened doesn't have saved. And the automated reprocessor, if you're using that, water with without disinfectant also should be checked, because as Aruna pointed it out, it can lead to outbreak and there are adequate report of it. The moment you use automated reprocessor, you think that put the scope in and then you walk off. That doesn't work actually as nicely as you dream of. What are biofilm? Very, very important as far as scopes are concerned. They're the bacterial group, which is usually on the, they gather on the wet surface. They secrete some polysaccharide, which is carbohydrate, and so that there's a film around the bacteria which protect them. And that biofilm cannot be penetrated by any disinfectant. So all this while, what I have been saying is organic matter or the bacteria should be manually cleaned off, because you don't want biofilm to be formed. However, disinfectant cannot penetrate it, but bacteria can come out. It can remain in the endoscope, it can remain in the disinfectant, it can go to the patient. And this is the reason where infection or outbreak can happen. Where do they form? I'm sorry. They form everywhere. Endoscope, the pipelines of the endoscopy room, in the automated reprocessor. I also spoke about the basin of endoscopes, the disinfectants. How do you prevent? Cleaning. Prompt, meticulous, manual cleaning. The last thing which is important, which is also the theme of our seminar today, is the safety. The staff has to be trained. I'm not going to talk too much about it. The PPE in the endoscopy suit is very important because there could be splash also. Hand hygiene is important. There should be eye wash and shower. Vaccine, health check, competency, certification from manufacturer, other companies is required. I've already spoken about the environmental safety. If you're using aldehyde, there is an exposure limit. The guidelines would tell you that. So you actually can monitor whether it is, the air vapor is within the limit or not. If you're using, especially in less ventilated area, there has to be a spill containment plan, and the glycine is considered as antidote. Also, when you throw away all this disinfectant, it cannot go in the regular water supply. The hospital needs to neutralize it and then discard it. STP do not work because STP work on the principle of bacteria in the water. So you have to have ETP for that. And a word about PPE. A face shield should be worn. I'm sorry again, that has been missed out here. Apart from everything else, the goggles are also not considered sufficient because of the vapors. And the gloves, which are not compatible, because most of us used latex gloves, what is not compatible with glutaraldehyde or OPA are latex, PVC and neoporin. So you need to look at, if you're wearing gloves and putting your hand in the glutaraldehyde, glutaraldehyde is going to penetrate through your latex. There are some unresolved issues, like when do you repeat HLD? Suppose if you have disinfected a scope, hung it, and now for 4 days you do not use that particular scope for the next patient, then what happens? Is it sterile enough or disinfected enough for the next scopy? However, the guidelines are not there. There are people who have spoken about microbiology negative culture or quarantine scope unless you proven that it is sterile or disinfected. But there are no guidelines. So in your institute, you will need to take a call depending upon your workload. So should you disinfect it again is the question. The storage space, endoscope storage space, how many scope can be hung together in one cabin, because the distance will decrease more if you put more scope, and is that okay enough, because you are going to then manually handle it and then you might just contaminate the area. But those are unresolved issue. What happens if there was a breach in disinfectant? Meaning if you have given a culture and then you have used the same disinfectant and then now you know that there were some bacteria present, then what do you do? So then it is like a recall process. Ujjwala has already spoken about it and Tushar is going to speak. So you need to basically have record of which scope was used on which patient at what time and what efficiency check was done for disinfectant. And you also need to know if you have any infection that happens in your unit, and that is how you're going to manage the breach in HLD. And that is the last slide that I have. So my take home message, that slide is missing again, but my take home message is one, that if you can't measure, you don't know. So please look at the infection, try to figure out that there is infection, look at the patient's outcome after the scopy. You could have many patients and it might be difficult, but that this is important. You should know if there is any trend of becoming, if there is any trend of outbreak happening, look at the water quality and look at the patient safety. And the most important, the last but not least, is look at the disinfectant is working properly, because that is going to be your mainstay. Thank you very much.
Thanks a lot, Shweta. And I am going to be handing the next session over to you for the next bit of.
Yes, so we are towards the end of the session, and we have Tushar here. Tushar is my colleague. We work together closely in infection control committee. He has about 16 years of 18 years of experience. I'm so sorry, Tushar, for that. But what I would like to talk about, Tushar, is that we undergo a lot of audits as a hospital, and for every audit, every person, every auditor would tell us that we have the best CSSD department. So that is what Tushar is all about. Tushar, over to you.
Thank you, madam. So basically, I am going to present this on this recall process. So first of all, first understand what is recall process. Recall process is whenever a breakdown in the sterilization system is noted, either by user or by the CSSD, all packs sterilized by the faulty machine is immediately called back from the respective areas where the sterile packs has been supplied. The recall process is fundamentally designed to minimize the potential damage. Potential damage means to avoid the hospital-acquired infection due to an error occurred in the system or the equipment or the process. So for things to follow, we require some basic things that we have to follow for the recall process. So every pack or every item going through the sterilization process must have the external label, which includes the set name, sterilization number, load number, sterilization date, expiry date, and class 1 chemical indicator. This class 1 chemical indicator, after going through the sterilization process, that will change. So from that, you will able to know that your pack has gone through from the sterilization process. Also, in addition to that, each set or the pack going through the sterilization process must have the class 5 chemical indicator, which is to be placed inside the set. Then after placing all these things, then every item before loading in the sterilizer, you have to note it down on the sterilization record book. Then after successful completion of the sterilization cycle, issue records has to be maintained so that you can track easily which set is issued to on the user also. So basically, this is a one sample set which includes the set name, then the sterilization date, expiry date,
And these are the few indicators. Means this is a three-line documentation label that contains your sterilizer number, then your load number, your packing date, and the expiry date, and which contains that class 1 indicator, which uh, which uh, which will indicate you after sterilization key that pack has gone from the sterilization process. So basic requirement for this is that all the sterilization quality indicators for the sterilizer used on the patient should be stick on the patient file. Means whatever you are sticking on the sets or whatever you are keeping inside the sets, after using on that particular patient, you have to preserve those indicators so that the patient should, in case of any infection or in case of any recall, you can easily trace the record of that particular sterilization cycle. And for reference, quality indicators color changes chart from unprocessed to processed should be easily available with the user department. So basically, these are the few things. This is a record what we have to maintain in the CSSD. With the these are the sterilization parameters and these are the loads what we are keeping in the sterilizers. So this is a record what we are maintaining in the CSSD, and as I have told you, these are the means results of the packs we have used on the patient, that we have to stick all these labels used on the patient file. So this is helpful while in the recall process. So basically, we have made this CSSD quality indicator chart, and that is distributed to all over in the hospital, so that the sisters are easily able to uh, compare it with the before sterilization and after sterilization also. So these are the few indicators that we are using and which is useful for recall in the recall process. These quality indicators are often used to determine how well the department is meeting its objective of producing the proper quality of the goods and the service. So now going to talk this on the recall process. The steps necessary for the recall based on the types of sterilization of failure. If your biological indicator failed, then as Ujjwala ma'am told, recall and quarantine all the sterilized packages in all loads back to the last negative biological indicator. So daily biological indicator practice is necessary for to minimize your this thing load. Then next is failed internal chemical indicator. Then recall and reprocess all packages in the same load as those with the failed indicators. Means for if your external indicator failed, your internal indicator failed, or if you found any wet load, then you have to recall and reprocess all the packages from the same load. Then in the recall process, locate the sterilized packages by packing date and load number on the package. So this three-line documentation label is useful to locate that sterilized package which you are going to be recalled. All the items from the faulty load need to be retrieved back from the user department for the re-sterilization. Means you have to just check the whatever load you have issued to different departments. Then you have to call to those departments and we have to take back all the items that you have issued to particular department for re-sterilization. Again, receiving those items, you have to repack it. Don't blindly sterilize on on that packaging material only. You have to repack all those things. You have to do the fresh labeling also. You have to do the fresh sealant documentation label also, and you have to put all this recall load in the fresh sterilization cycle. Notify and document recall incident to all concerned departments, medical director, infection control team, so that everybody should aware of these things that you have recalled certain load. Then document any sterilized package which we are not able to record. Means if any pack that is you have issued to certain user and that user have already consumed or already used that pack on certain patient, then you have to document certain packs. So after recall, you have to also follow these are the few steps. If failed biological indicator uh, is then you have to do the retest of the sterilizer with the biological indicator test. It fails again, then you have to repair the sterilizer, and if it get repaired, then only you have to use that particular sterilizer. If the biological indicator retest is negative, then only you have to use that particular sterilizer, and review the procedure for performing the biological indicator test to determine if failure could be have the mistake by the operator. Means if the technician has not properly keep that biological indicator in the incubator, that also may be the one of the reason that it may get failed. If the failed internal indicator, review the packaging and the loading procedure, because sometimes because due to the overloading the internal chemical indicator may not change. Same like for the this external chemical indicator. If weight load you form the weight load, then review the loading procedure to determine the cost. And if the weight load persists continuously, then inform the biomedical and the company person, and get it sure the sterilizer is repaired before use. So conclusion is that lists down all the action taken to prevent the reoccurrence of these problems. Then you have to do the documentation of all the reprocesses and all the these things. Training. You have to provide the training to the user. You have to provide the training to the technicians, and mock drill. This is very essential. Mock drill is very essential, means you will have the idea ki in case of actual recall or actual thing, what process, what steps you have to follow. So that's it from my side, ma'am. Hello.
Yes,
Any
Tushar.
question?
We will take it at the end of the seminar. Tushar, thank you very much. It was very practical, and we'll move on to the next session. Next session is Dr. Rohini Kelkar's session. Rohini ma'am, again, do not need any introduction. She has been at Tata, and now she's at Metropolis and Reheja Fortis. A giant in her field. Ma'am, over to you.
Thank you, Shweta. I know I don't need any introduction, and I think we are running short of time. So I'm going to discuss alternative sterilization technologies. So I think since all of you are tired listening to sterilization, and you already know that the CSS is the heart of any healthcare organization, I'm putting a question to you in a lighter vein. And that is, mirror, mirror on the wall, which is the best technology of them all. If anybody can answer my question, I think I will hand it over to you to complete my talk.
So we all know that sterilization is a terminal process. This has been discussed, and every step, right from cleaning, packing, all of these are important. But let me remind you that there is no single sterilization process that is suitable for all medical products. And we need to optimize sterilization with alternative technologies. You've had a treatise from Dr. Malkit, who gave an overview of the technologies, actually all the technologies. And I'm going to restrict to only two of these technologies, which is low temperature sterilization. Because when we have a heat sensitive instrument, a moisture sensitive instrument, like the scopes that have been discussed, we know that heat damages many of these equipments, and we need to look for alternative low temperature sterilization technologies. What is the ideal temperature? Ideally, now, as you all are aware, there is nothing like an ideal alternative technology for low temperature sterilization. The ideal requirement should be a temperature less than 60 degrees Celsius. The reason why we have this is that there are many complex instruments. Every day there is a new instrument coming in. Today we have a harmonic scalpel, tomorrow you have something else. And the problem that we are all facing is that the microorganisms must be in direct contact with the sterile for inactivation to occur. So it's not really as it's not as simple as the the point is that the alternative technologies have been in existence for many years to come, but currently there are only a few of them which are approved by the FDA. I actually had put in a slide which had steam and formalin as an alternative low temperature technology, which I took off because formalin is so controversial. We all know that. So I thought it was safer to keep these controversial things out and focus only on the two practical in-use technologies, and that is ethylene oxide and hydrogen peroxide gas plasma. Peracetic acid as a high-level disinfectant has been discussed, and I'm not going to touch upon that. And of course, ozone is the next approved technology. I know we'll have more and more technologies coming in the market as time goes by, but suffice to say that we need to discuss these two for today, and I think we've had quite a feast of sterilization. So I'm going to move a little fast because a lot of this is known. It's interesting to know that ethylene oxide was discovered way back in 1859, and it was used historically in agriculture and fumigation, etc. It's a colorless, flammable gas. It has been, a lot of it is being produced, but the real utility of this gas came into being in the 1950s. And again, this was when we started getting plastics. The plastic revolution brought in technologies that we needed to sterilize heat-sensitive plastics and medical devices. So the initial gas that was used with ethylene oxide was a formulation of ethylene oxide and CFC. Now, CFC we know is not environment friendly, and they have requested for environmental reasons to get rid of CFC. So today we're using 100% ethylene oxide, which is being used instead of CFC being added to it. Ethylene oxide, as we know, is not only flammable, but it's also been classified as a carcinogen. And many people, since I've worked with cancer in a cancer hospital all my life, many people have asked me this. So the two chemicals which we have been using in healthcare for sterilization and disinfection, one being formaldehyde, also a proven carcinogen, and today when we also have ethylene oxide, which is a carcinogen. So all of us today are trying to phase out carcinogenic agents as it stands, and we're looking for better, safer technologies with low temperature, as I have already discussed. There are important parameters that we need to consider in the ethylene oxide sterilization process. That is the gas concentration, where there is a range described, the temperature, as I said, it's a low temperature, less than 60 degrees Celsius, the relative humidity, and the exposure time. What is the basic mechanism by which ethylene oxide acts? Yes, it kills microorganisms by a chemical process of alkylation, so that the effects of this resulting in cell death are actually irreversible. We require humidity in this process because humidity allows penetration of ethylene oxide. As I said, in low temperature sterilization, there is a requirement that the sterilant should actually penetrate the items being sterilized. And we know that in ethylene oxide, the humidity actually helps to heat the load and transfer ethylene oxide through the load. So we do require relative humidity as per the set parameters of the sterilizer. The temperature, we know this is preset by the manufacturer, and it's important for us to note, I'm aware that in many institutions where we have old ethylene oxide sterilizers, they're literally like boxes with hardly any controls and standards. I think it's high time that all of us updated our equipment with more sophisticated machines. I'm aware that they're going to cost us money, but then we all want to resort to cost cutting, and that's not acceptable with sterilization because, as I said, every penny you spend on the CSSD is probably worth a pound that has been spent. By now, I don't know how much of this has been discussed. Unfortunately, I joined in a little late because I had some other commitments. But every sterilization method today, we have stringent packaging requirements. I'm often asked this question when it comes to steam sterilization. Can we not pack in linen, ma'am, because it is so much cheaper? Why do we have to invest in medical grade paper? Now, that's a question that I'm not going to answer because today, with the amount of sophistication that we see, the sophisticated surgeries, and the risk because of improperly sterilized equipment, I think we need to make sure that we follow the norms and we follow the standards using whatever is required for sterilization and packaging as well. So with ethylene oxide, it's plastic film coupled with paper, which performs well for sterilization and aeration. These are all available through standardized patented products. And I, for one, feel that we need to stick to these and really not cut corners in terms of packaging and then storage and things like that. Humidification and drying before EO gas sterilization is essential. Drying is a very, very important step, which we often forget. Just as we talk about drying your hands, I think drying anything that is to be sterilized is also very important because with ethylene oxide, the presence of moisture and water has other problems, which we'll talk about a little later. The biological indicators have been discussed exhaustively by Ujjwala, so I'm not going to go into those. Residual ethylene oxide requires aeration, and we're going to talk about the steps in ethylene oxide sterilization. I think there was a correction to be made in that slide, the earlier slide for the agent, the biological indicator. Apologies for that. The conditioning and air removal these are the steps in the process. So there's conditioning and air removal. As you can see, air removal is important for every sterilization process that we use. Humidification and vacuum check. There is charging of the EO gas. We are using cartridges which are punctured and then the gas enters the chamber. The sterilization process is completed. The chamber load remains at this concentration for the set temperature, humidity, and proper exposure time. And then the exhaust, and then there is an exhaust step when the EO gas is removed from the load and the chamber. Honestly, I'm not an authority on this, but we understand, once you understand sterilization, the need for it, you can really understand that every step in this process is very important. So once the EO gas is removed from the load and the chamber, we have this step of aeration. Now, aeration usually is done in the same chamber, or it can be done in a separate chamber. And of course, this is the problem that once you've sterilized the equipment in this, it has to be aerated because the ethylene oxide is so toxic that it should not be present on any of the medical devices. This is another point that applies to even the high-level disinfectants that we're using. The washing step post-sterilization with any of these is very important. There are a few points that I'll talk about the high-level disinfectant a little later, or if there are any questions. That's not the scope of my my talk really. What are the, sorry, I'll just go back. What are the challenges? This is an important slide. The tendency to reuse single-use items. I mentioned in my first slide that it is the reuse of medical devices that has brought in low temperature sterilization because most of these are plastics. everybody feels that once you put something into a sterilizer, lo and behold, it's like a magic wand, it comes out sterile. Please remember, unless you can actually clean and dry an instrument, this is a very important step. Unless you can dismantle the instrument, you can never ever just put it into a sterilizer and hope that it's going to be sterile. Even if you put it for a million years in a sterilizer without cleaning, it is not going to get sterilized because the organic matter is going to prevent penetration of the sterilant that you are using. So cost cutting can actually jeopardize these lives. I mentioned the packaging materials, assembly and wrapping. These are all issues for ethylene oxide. Sterilizer loading procedures, selecting the appropriate cycle, and preconditioning the environment. What are the advantages? This is an effective low temperature and low moisture levels. The gas diffuses easily through commonly used materials and complex devices. There are no lumen restrictions. The gas is non-corrosive. And today, we are using 100% ethylene oxide, which is relatively safer in the sense of flammability. Of course, I'm not going to comment on low capital costs because I think you can get sterilizers for different ranges. It's up to you what you're going to spend. I would spend much more on a sterilizer than I would on doing up the hospital operating rooms with aesthetic lamps and things like that. This is the disadvantages. Of course, we all know long cycle length and the need for aeration. This is the most important step. And I think in the olden days, we really didn't bother about that. You just leave it outside when the sterilizers were first brought into existence. But that's not acceptable today. But there is a need for aeration, and that, of course, takes time. We know about the CFC and the depletion of the ozone layer, and of course the carcinogenic nature of ethylene oxide, flammability, toxicity. Items to be sterilized should be completely dry. This is very important because if you put in a PVC item, you get very toxic compounds like polyethylene glycol and a whole range of toxic products. Again, I'm no authority on these, so I'm just going to leave it for you to say that, for you to understand that the presence of water, unless the equipment is dry, it affects with the sterilization process. Yes, ethylene oxide is irritating to skin and mucous membranes, and the sterilizer must be checked and maintained because sometimes you can get leakage of ethylene oxide gas, and that can be detrimental to healthcare workers. Having looked at ethylene oxide, I'm going to quickly move on to the second important sterilization methodology, which is very popular today. But again, I think because of the high cost of the equipment, one is avoiding these. But let me assure you, when it comes to a CSSD, we should not look at the cost, because that is I'm going to repeat, that is the heart of the healthcare organization. Unless you have safe, we are looking at environment, we're looking at so many things when we are operating on patients. But we are forgetting that actually it's the CSSD that is the most important part of the hospital. If you really want to survive, the CSSD supplies every and any area of the healthcare facility. So this is an important technology that we have available today. It is dry, rapid, low temperature plasma sterilization process. Again, it's useful for heat sensitive instruments. And I know that people are putting in cameras, they're putting in shoes, whatever you want, everything is being put into a plasma sterilizer. Having worked with plasma sterilizers for a long time, we all know that you can actually put in anything. The low temperature sterilants, again, just to recapitulate: hydrogen peroxide, gas plasma, peracetic acid, and gas plasma. Now, an interesting point, what is this plasma? Plasma is nothing but the fourth state of matter. I'm not going to give you too many details, but when you break that molecule, you actually release a cloud of ions, electrons, and free radicals, and that is what plasma consists of. This is the process where we use radio frequency energy to actually break the hydrogen peroxide molecule, which is first hydrogen peroxide is vaporized and the molecule is broken into plasma, and it is the ions that are generated that actually work as sterilants, because hydrogen peroxide in the vaporized form begins the process, and then it is the ions which are released that actually complete the process. What is important in this is there is no toxic residue. So you can take out the equipment and get on to using it. So this is an important point, because what is left behind is oxygen, and there is water vapor or water. So these are totally non-toxic products at the end of the sterilization cycle. So the sterilization process, it's a gas plasma system. The gas, there is vaporized hydrogen peroxide which diffuses and penetrates all parts of the load. Then plasma is created with radio frequency energy, and that actually, so this is to summarize what is the sterilization process in a gas plasma sterilizer. This is just a cartoon showing you how the system is. This is the cassette, the chamber, the RF source, and the vacuum pump that actually conducts the sterilization process. So in the process, this is the packed material that is shown inside the sterilizer. The instruments are to be washed and dried completely. Again, we have packaging material. Classically, Tyvek pouches and polypropylene wraps are used for this. It is recommended that you do not stack the trays. In a conventional steam sterilizer, we often stack trays, but here we do not stack trays, because otherwise the hydrogen peroxide will not be able to penetrate. You leave at least an inch of free space between the load and the electrode to allow the hydrogen peroxide to diffuse, because everything depends on diffusion of hydrogen peroxide and generation of plasma. The first step is the generation of a vacuum. It, of course, detects moisture. And nowadays, they have systems in the newer sterilizers where even if there is, you don't waste a cartridge. If it detects moisture, it aborts the cycle and your cartridge is actually preserved, or it corrects the process that is at fault. Then there is injection, as I mentioned earlier. There's injection and vaporization of hydrogen peroxide. There is diffusion into the packaging material. Then there is the generation or the creation of plasma from the radio frequency electrode. Then there is ventilation. HEPA filtered air is admitted into the chamber, and then you have what comes out is, of course, the sterile equipment. Yes, a lot has been discussed about the indicator systems that are used. Again, I'm no authority on this, but there are rapid systems where you can get a result, as mentioned by Ujjwala, in about 15 to 25 minutes. So we are using what is recommended by companies is to use process challenge devices and biological indicators for hydrogen peroxide gas plasma sterilization with every cycle. I know that sometimes we are required to compromise on these things, but I'm not one who believes in compromises when it comes to sterilization. Geeta won't agree with me, and I'm sure she'll want to pounce on me when I finish this talk, because I'm aware that, yes, all of us cannot afford the luxuries of what is actually ideal. So we have to be realistic. And yes, I agree, we do compromise on certain occasions. But when it comes to implants and the likes, I don't think we should compromise. So we need to prioritize our equipment and decide how we're going to work with constrained resources. What are the advantages of this? It enhances patient safety because there is no toxicity involved. As I mentioned earlier, hydrogen peroxide is one of the safest. What is remaining is a non-toxic oxygen and water. The turnaround time is much faster because no aeration is required when you compare this with the ethylene oxide sterilizers. The integrity of instruments is maintained. Like I said, you can even put in a shoe inside and it'll still get sterilized. I don't know what will happen if it's a stinky shoe that is contaminated. But rest assured, at least the bacteria will be killed, even if it's a dirty shoe, as long as it's dry and it is maintained as per the requirements of the equipment. An important point and a question that I have often asked many manufacturers during my career at Tata Memorial Hospital is, what is the compatibility of these systems, of the complex equipments? And my advice to everybody is that if you're bringing in a new equipment and you're sterilizing it because the equipment is expensive, many times we are reusing it because of several constraints, etc., please ask the manufacturer about compatibility. I often ask for a list of items that can be sterilized in this particular unit or that can be sterilized by, say, peracetic acid. because we are using very expensive equipments. And I think if something gets damaged, you and I are going to be held responsible. So many companies actually will give you a list of the equipment that can be sterilized, and they will give you certification of compatibility. So please make sure when you're using new technology, of course, gas plasma system is not new, it's about 20 years old, if not more. We should actually be a little cautious and make sure that we are clear in what we are putting into the newer technologies, which are low temperature. Also, we need to assess the method of cleaning and packaging for that particular item, and we should be able to dismantle and clean the equipment. I know complicated laparoscopes and endoscopes, not endoscopes so much as laparoscopes, fiber optic scopes, need to be cleaned thoroughly before you can put them into any such sterilizer. So I've tried to be very brief. I may have made a couple of mistakes because I'm really no authority on this, but I think we have all understood how important it is to make sure that we follow standards that are actually acceptable in our area of expertise today. Thank you.
Thank you very much, ma'am. That was a very, very comprehensive and illustrious lecture. As always, a brilliant talk given by you. We will take the questions if they come in chat because we are running short of time. Ms. Netra is heading Hinduja Hospital CSSD. She's there, so she can probably do the experience sharing because she's been running the CSSD for many years and now even teacher for several years. Netra, over to you.
Thank you, Dr. Shweta. Thank you. So basically, we are talking about quality in CSSD and experience sharing. Like we heard from all the speakers about quality. What is quality? What is quality? Is at the end of the day, it's a customer satisfaction. So what are the customers which we CSSD caters to? They are nurses, physicians, and surgeons. And how can we satisfy them? By giving timely delivery of sterile supplies, accuracy of products in terms of count and quality, benchmarking the processes with national or international standards, and believing that things can always be done better and undertake improvement and take fact-based decision. This is something we CSSDNs, I would say, thrive for, that taking fact-based decisions and believing that we can improve upon, and training and checking the effectiveness of training, which everyone obviously spoke about. Now, when we talk about quality, to my mind, first thing what comes is the equipments, because if you don't have good quality of equipments, and of course the manpower comes. So material, manpower, equipments, all these are important. So if you do not have good quality of equipments, then probably you need to have more check on your processes and all. So to avoid that, you need to have certain criteria on purchase of equipments, which when you're purchasing an equipment, we should look forward for, the equipment's manufacturing country of origin certificates, its statutory body certificates, the material which the equipment is made up of, the compatibility of material with the sterilants, and the items which you are going to kind of sterilize it. You can look into for eco-friendliness of the equipment, wherein in today's era you get autoclaves or the machines. Most of the machines have water saving capacities, wherein you could control on your water, reuse the water, and you can optimize your resources. The utility requirements, like what is the water quality, which we all talked about. What's the water quality which is required in CSSD? For sterilizers, you will need one kind of, water quality. For final cleaning, you need a different kind of water quality. What are the electricity requirement? And of course, the noise level of the machines especially when it comes to the ultrasonic machines. The transducers which are used in ultrasonic machines are, kind of generate a lot of noise. So noise level also has to be looked into. So the acceptable level is 70 dB. The transducers which generates the ultrasonic frequencies, It ranges from 20 to 400 kilohertz. So now the higher the frequency, it can be used for the delicate instruments. The heavy instruments would need a lesser frequency ultrasonic waves to which will kind of be used in the machine. So all these small but important points are important, and also the running cost of the machine, wherein you need to look into the consumables which are required, and in given the scenario, like we are using different kind of packaging material. Okay, so then compatibility of that particular material with the sterilization processes is equally important. The stability of consumables, which when it comes to the stability of, especially the low temperature sterilization, wherein you use the sterilants. The sterilants have a definite stability. So that also needs to be looked into. The software for ease of record maintenance and record retention. So connectivity of software, the which should be taken care of, wherein you can have less of manual errors. So it is connected to the machines, and whatever is processing in the machine is recorded, documented, so human error is eliminated. Now moving towards different zones of the sterilization areas. The first thing is about the decontamination area. We talked about, everybody is aware, everybody, the CSSDNs are aware about, we have three different zones: the dirty zone, the clean zone, and the sterile zone. The dirty zone has different ventilation requirement, the air requirement, the air pressure requirement, the flooring requirement. So all these are documented in manuals and should be documented in our own manuals, and also can be referred in NABH, can be referred in guidelines, can be referred in CDC guidelines. So if they talk about, but eye wash unit is something which is also a must in your dirty area or decontamination zone, wherein you're using chemicals. So, there are chances of chemical splash, and you need to have those splash removed immediately within few seconds of a time, so that your injury or personal injury is stopped. So that eye wash unit is a must in decontamination area. You get chemical storage cupboard with proper ventilation system. So that is something which has been upcoming in the market. So we need to look into these kind of things which you can improve upon. Okay. Otherwise, chemical storage is just kept anywhere and everywhere, and then you have fumes which are generated through chemicals. There are spillages, then there are contacts. So all this could be avoided. You need to look into the waste disposable system. Now in today's era, you get paddle operated closed container system with labels, wherein you have a easy identification. So your error elimination and your proper segregation is done of all your biomedical waste. You get yellow, red and green bags with a coding with a biohazard label. So it's ease for operations for the operators who's working in that particular area. Your PP, though it is not stated over here, which is definitely mandatory, you need to have closed shoes wherein the injuries could be protected. Then you need to have a gown, and a visor in today's era is must, or at least a goggle to protect your eyes and all, and a cap and mask definitely. Gauri talked about trolleys. The trolleys who transport the unsterile goods should be closed. The trolleys for transportation of sterile and unsterile goods should be kept separately, especially for this. If you get airtight trolleys to avoid those cross contamination of supplies, when you're carrying the dirty supplies from one area to another area. So these are the factors which we need to look into. And also a trolley wash area in your decontamination zone is preferred, and it is mandatory ideally, but due to space constraint we cannot have many things. However, your processes should be such that you could actually take care of these aspects while you are reprocessing things in the CSSD. your flooring in the CSSD, especially in the washing area. You know, the flooring also you have Kota, vinyl, epoxy flooring. So there are three different grades and types of flooring which are available. Kota is very easily to clean and easy to maintain. So one need to decide based on your your own criteria, or your discuss with your infection control and decide upon whether Kota flooring is very easy to clean, very easy to maintain. Vinyl is a little better flooring than Kota flooring. Epoxy is best flooring. However, the vinyl flooring and epoxy floorings, when you have heavy load of transportation of carts in the CSSG, there are chances that you may get cracks and all on the flooring. So when you are considering about flooring, all these small points needs to be looked into. Now, as I talked about water quality, so it is recommended that everything which is clean, a final rinse should be done with RO water, or at least demineralized water or soft water, so that you get less during your process of sterilization. Then the items is sterile, you don't have any components or any minerals on your instruments which are processed in the sterilization processes. Now you get efficacy check of these machines. You have, in Indian case scenario, you have ultrasonic machines and washer disinfector machines. Whereas if you go abroad, you'll more or less find more of washer disinfector than of use of ultrasonic machines. So, but this efficacy of the machines can be checked with the help of indicators. You get sono check for checking the efficacy of ultrasonic machines, and you get chemical indicators with blood stain on a strip of indicator, which can be used in washer disinfector. Never ever, people often mistaken are often mistaken wherein they use washer disinfector indicators for ultrasonic check. One should not do that. The indicators are meant for specific purpose, so we should be using specific indicators for specific machines. Then only we are able to kind of get the proper results, and when we should be able to get the check appropriately. And as all of us know, washing is the most important aspect in sterilization process, because anything which is unclean cannot be considered as sterile. So this is the primary check has to be done on your washing processes, wherein Gauri talked about, I think Gauri talked about ATP, visual cleaning and all. So if we could use those things, nevertheless, at least check the efficacy of the machine. So you are guaranteed, you are sure that your machine is functioning appropriately. Then change of your chemicals, or change of your detergents, and change of your water when it gets dirty. That time frame has to be decided. Either you decide the time frame, and at end of every 8 hours, end of every 4 hours, and besides that, as and when it is found to be dirty, that needs to be checked into. Coming back to ultrasonic machine, we need to also look into the aerosol generation while the ultrasonic is in use. So if possible, preferably you close the lid of the ultrasonic machine when it is in use. WD though will not work without closing the door of the machine, so there is no aerosol generation. In washing area, when you are using the water jet, you are actually generating aerosols. So the lumen articles, when you are flushing it, the care should be taken that you have a water bath, and the instrument tip is beneath the water bath, and then you flush the water, so that you protect yourself over there. Use of PP, I've already spoken. There's a concept of double gloving. I don't think we should have that concept over here, whereas the gloves should be very sturdy, long cuff, to protect the staff working in this particular area. So this is something which I could think about putting up to y'all on decontamination processes. Now we come to a clean zone, wherein we have, instruments check, wherein you actually assemble the instruments. When you assemble the instruments, obviously you check for the cleanliness of the instruments. If it is found to be unclean, you have to return it back to the washing area, get it clean, properly done, dried, and then use it. Now, instruments are checked for its proper working condition, should be checked for its proper working condition. The scissors tip should be checked. The needle holders chip, especially with the tungsten carbide, should be checked whether the tungsten carbide is chip off, whether it is intact. If it is chipped off, it should be given back for repairs, and then, a new fresh item, fresh needle holder or instruments with TC, especially with TC, because there are chances of TC tip getting chipped off. So take it out for repairs and replace it with a good one. You need, if required, you can have a magnifying lens over there in your assembly area, which will help you check all these instruments. Your illumination, though things are not listed over here, but I'm just talking about it. So illumination in this particular area is equally important. There is a standard to which your illumination is required, and especially when you have people of mixed age group, the younger generation can see the things much faster than the people like of our generation, the older generation, with spectacles. So they will need little extra illumination as compared to the younger generation. The tables which you are, which are installed in assembly area should have proper illumination. Then if you have windows or, open windows wherein you get the natural light, it will help us check the items properly for its cleanliness, appropriateness, tidiness. And then once the instruments are checked, you need to have a checklist of instruments of every set constituents. So if a set of is used for a basic surgery, if a set is used for a cardiac surgery, you need to have a list of constituents of the sets, which talks about the basic set will have XYZ instruments, okay? And they should be placed in an order, wherein order of use, wherein we talk about, firstly, you need to have a towel clips to drape the instruments, so to drape the trolleys in OT. So you need to have towel clips first, then the scissors, then your arteries, and then sponge holders. So likewise, a list has to be made. Same if you're using linen, the list should be made as per uses. So the item which is used first should be, kept on the first priority, and the item which is going to be used and at the end should be kept at the list, so that it is easy. You have a better sterility maintenance at the time of when the nurses are opening the sets or the opening the packs. So that is how you take care of, in your assembling area. Now, when it comes to a packaging of the materials, there are various kind of packaging materials which are available in the market. You have linen, you have paper, you have peel pouches, your tie bag pouches, you have your container system, you have open container system. So how do you choose the packaging material? The packaging material is actually choose based on the items which you are going to pack into. If normally we are using linen, as Rohini madam rightly said, we should avoid use of linen if possible, because it generates a lots of lint. Then there are lots of tears and holes and stains which cannot be seen with naked eyes. So try avoid using linen. I too am trying, been able to succeed to a certain extent, not to 100%, but we must aim towards good practices. Now, then there are SMS, then there is containers. So when you talk about containers, you get containers with, the filters, you get containers with valves, which does not require any kind of packaging material. So you get rid of packaging material, you have items sterile until the container is open. The filters are, are changed after certain frequency. So there are filters which can last for 50 cycles. There are filters which can last for 100 cycles. The valves, the containers with valves are, kind of used until the valve is functional. However, when you're using these containers, you need to check once again the efficacy or functioning of that container. Containers with valve have to be checked with, with the help of biomedical engineering, whether the valve is appropriately functioning or not functioning. The filters are reusable. Then you get locking mechanisms for this. You can, the moment a container is open, it becomes unsterile. Now, coming back to expiry or the shelf life of the product, as I said that it depends on the packaging material. Generally, it also depends on the condition in which the item is stored, the number of times the item is handled. Okay, so it does not mean that anything which I packed it in SMS will last forever. So the more I handle, I am introducing organism into that packaging material. So all these factors, when you decide an expiry of a product, all these factors needs to be looked into or consider, and then one can work upon and decide for that particular organization that okay, the items which are packed in so and so material will last for so and so days. Okay. However, you can give the shortest expiry for items which are packed in linen for the various reason of having holes and all in on the instruments. It's not a good, uh, wrapping material. And then similarly, items which are packed in paper bags, that should be medical grade. Ideally, they should be medical grade paper bags, should last for a longer time. So we try to give, expiry of 7 days and a month and 3 months and a 6 year. But the items which are packed in the containerized system with valves or with filters will remain sterile unless and otherwise they are open. So that's an advantage of having this system. Cost benefit analysis needs to be looked into based on various aspects. Now, the other advantage of you nowadays you get tracking systems. There are a couple of hospitals which I have seen in India also who are using tracking systems. So which talks about tracking the instrument right from the use of the instrument in OT and uh, sending it to CSSD. So the instruments are tracked for its count, its accuracy, its life. Now, the advantages is that you get to understand a particular instrument is there in the set. If the set has about 90 listed, about 50 instruments, when the set was open, it had 50 instruments. When the set is used, it still had 50 instruments. So there's no instrument which is missing, which is gone. There is no chance of any instruments remaining anywhere in patient's body, or to that matter, it's gone into any garbage or anywhere. So that is something which is an advantage of having a tracking system. Also, you get to understand the life of the instruments. A instrument which is purchased maybe in 2015, and now it's time for you to repair the instrument, so please take it out, it's functioning, non-functioning, so you have those records. So tracking system helps you to understand the life of the instrument. You get better traceability of the packs. Now, in coming to sterile zone, we have traditional sterility maintenance of Bovidic, airlick test, physical indicator, chemical indicator, BI, event-related sterility, parametric release, case card supplies of the product, which is something which I thought of adding on to a quality improvement. So now when you are talking about Bovidic is done on a
Mira, I'm
pre-packed
sorry to
sterilizers.
interrupt. I'm
I
really
should
sorry to,
ask.
yeah, but if you
Yeah.
can wind up
Yeah,
because
it's just two
we are
slides,
running
nothing.
late. Yeah.
I
Thank
know, just two slides.
you.
So I'll
Yeah,
just quickly
sure.
talk about Bovidic. So see, there are Bovidics in the company which gives you a sterilizer. There are companies which give you Bovidic cycle of 1.5 minutes as against the standard cycle of 3.5 minutes. And your sterilization cycle also should be, stir hold time could be 4 minutes. So it's once again, IFUs, talking to manufacturer will definitely help you decide on what cycle you need to process. The frequency, I'm sure everyone is aware of, a daily Bovidic cycle, air leak on a weekly basis, physical indicator every cycle, chemical indicator in a challenge pack in every cycle. I think Ujwala talked about, and many are talked about, so I will not take up the BI things. Shelf life of sterile product also I have covered. Event related sterility or parametric release is a concept which is practiced in European countries, which talks about, you release of sterile products based on your parameters of the cycle. If your physical chemical cycle is all right, you can actually release the cycle. Now, case card system will help improve the load processing, wherein your CSSD is running around to cope to X number of surgeries. So if you have a list of items which is kind of saying that today you have this surgery and you need these items, so if you have the system in place, your case card system definitely will help you. Traceability of instruments on patient use, especially implants, which is a need of an hour and which is also a guideline and a mandate. So unit, which I think Tushar covered upon. So you need to have traceability of items which is used on every patient, so that tomorrow if you have a medical legal cases, you can definitely say that our items sterilized in this particular item was perfectly, the quality improvement was perfectly, quality control was perfectly all right. Then there is something called as disaster management, which is required. You need to have a disaster management kit in CSSD, which is used in any on event of any disasters happening. So the CSSD's responsibility to check the completeness of the kit, timely delivery of the supply, and to conduct a mock drill. Now, risk stratification in CSSD is something which we did it at our end, wherein we have kind of made a chart of what are the risks for CSSD from CSSD point of view, which will involve, handling the goods in low temperature sterilization, then the sterile items, the loaner instruments, what happens if the set is incomplete and all. So you, based on that, you give your ratings and decide upon which one is very high on rating, and then you evaluate and understand that how do you kind of go about and rectify this and improve upon. So that is something which we are doing. Now, we have all those, quality control measures placed in CSSD. However, it will not be done unless you have proper policies. Once again, I'll just run through the policies. We have standard recall policies, as Tushar once again said, that we need to notify any recall to your infection control head. And, you do recall on if you have one biological indicator failure, we don't, put the machine off. We actually we have to run 3 consecutive cycles and then check for minor repairs of any sterilizer. You kind of, don't do all these 3 consecutive cycles. You just, you do your BI and you make the machine functional. You have your SUD policies wherein you need to have, in market you get tracking devices for SUD as well. So one can, think of using these devices wherein you could track, and then chargeability also becomes an easy. Of course, cost benefit needs to work out. Okay. Stock check of surgical instruments, which will help us, policy on stock check of surgical instrument, which will help us account on inventory management, supply chain management, wherein you need to have a policies with nursing and laundry, wherein you decide on the par, where you decide on the kind of kits which are required for surgical procedures, and updating the list time and again will help us do more better quality services. Staff privileging and credentials. So you kind of decide on the activities which is done by seniors will be this. The junior will be doing these activities. So, and then every year you just keep reviewing this privileging and credentials. Okay. Documentation control. So you decide that particular documentation has this particular number. So it is easy for retrieval. And record retention, one has to, once again, CDC talks about 3 years of record retention, whereas another standards talks about, WHO talks about 5 years of record retention. So one needs to once again stick to the standards and decide, and of course discuss with your IC head and decide on the policy on record retention. And policy on documentation and review of documentation, like how often you want to review your documentation and policies and processes. Ideally, at least it should be done once in a year. Quality control is a continuous, it's possible only with continuous training and adherence to process of documentation. Pre and post training assessment is definitely mandatory. With this, you also give rewards and recognition to your staff so that the staff is motivated, and then you achieve your quality improvement. And then you have incidents and reports. Now audits. Lastly, audits. So how often we should do audits. It's something which the organization needs to decide. It could be done every quarter, but and you need to have audit checklist. This is a sample of audit checklist. One can decide on based on their own processes. You have your SOPs, you decide what are the items which you need to audit, decide your frequencies of audit. Okay. And then you get your findings, you do your root cause analysis, and then close the findings and keep training and retraining and improving upon. That's how I think we could reach to a best quality measure. And thank you so much for patient hearing. And sorry for the delay.
Thank you very much, Netra. With that, we go to Mr. BP Singh, and thank you, Netra. It was really a good session. It's just that we are now running late. Mr. BP Singh, I've already spoken about him, head of Bridge Candy Hospital. Please take it over.
Good evening to all of you. It's my privilege to be part of HIS today. Today we are going to look after that experience sharing in establishing CSSD. As my earlier colleague had covered everything, nothing is left for me right now. So I would like to discuss that what are the things should be involved during establishing CSSD. We call as a CSSD is supposed to be, we call as a heart of the hospital. Without this department, we cannot run any of the operations or anything like that. So it is an integral part of today's modern hospital. Sterilization process is the essence of the department's existence. If whatever we are doing only for the sterilization purpose. So whatever the material which we are going to supply to the patient, it should be 100% sterile. We cannot say it is a 90% or 99%. Even a small failure in the following, the protocols will lead to the system failure. Before planning any of the CSSD department, we have to see that for every per bed, it should be 6 or 7 square feet per area is required for CSSD. If your hospital is 300 bed, it should be approximately 2000 square feet. While designing or placing this department, it should be near to your operation theater, cath labs, or any of the critical areas like ICUs and everything. Now we come to the design planning. Here, soil zone is there, clean zone, sterile zones. All our earlier speaker has mentioned about this, but again, we have to mention that what are the things are required while designing this CSSD. Changing room should be there, receiving counter, sorting area, washing, and again, this changing room for the clean areas, packaging area should be intact. Airflow should be proper, as Netra has mentioned in her slides, equipment area, low temperature room, trolley hold, changing room, etc., etc. So I don't want to go much in that. So the functioning of the department is very important. How it runs and where the instruments are going to be placed and which side your instruments is going to receive and from where it is going to be delivered to your sterile metal to the user end. Okay, so everything is mentioned over here. Now, manpower planning is very important. See, if we are having a 300 bed hospital, we have to plan what type of surgeries we are going to conduct. If it is a ortho surgery or a gynec surgery, we have to plan and what type of a machine automation we are having in our department. If we are going to go for a manual, so in that case, the manpower may be increased. And for technicians who are going to, we are going to select, they should be a science graduate. They should understand the human anatomy as well as the microbiology. Normally, candidates preferred with 6 months or 12 months certificate course, which are occurring in our hospitals as well as the institution nowadays. Earlier, there was no institution. So for any of the instruments, for any other CSSD, while planning for the equipment, we have to see that how many number of the OT are there, what type of the surgeries we are going to perform. Accordingly, we have to calculate the capacity of the sterilizer. For example, for a 300 bed hospital, it should be approximately 6 liter we are calculating. So at least 2000 liters should be there for the autoclaving, as well as different types of the sterilizer we are going to select. For example, ETO is there, plasma is there, and many other. Okay. Planning of the department. See, in CSSD, we have to plan that surgical instruments planning is also very important. That what type and what number of the surgeries you are going to perform. If example, there are two operation theater for the gynec, so accordingly we have to make that much trays or sets, and number of trays we have to decide for that. And financial planning is very important for any of the CSSD. And that means budgeting. It includes operational budget as well as the routine, means replacing of instruments, consumables. If you are going to think that your instruments is going to last for 1 year, 2 year, accordingly we have to make the budget for that. And last comes the quality control, then type and frequency. It's a very important. See, normally in CSSD, we are using biological indicators, chemical indicators, Bowie-Dick test, which we called as a quality control. Earlier, we were using a biological indicator, which we used to get a result within 48 hours. But right now, as Dr. Rohini Kilkar and Madam also told us, that within 20 minutes we are getting the result of the plasma as well as for the ET or for the steam sterilization. See, for any of the CSSD, it's become very difficult to it becomes very difficult to convince the management, because normally the space which is given, it is in the basement area, or sometimes I had seen in many of the hospitals, it was given on the terrace, which is really ridiculous. It should be always to be nearer to the operation theater or the critical areas. Zoning of the department is important. Equipment capacity, as we had all discussed earlier. See, decentralized versus centralized CSSD. Earlier, we used to see in many of the hospitals that TSSU used to be exist in the hospital. But nowadays, centralized CSSD departments are mandatory at every hospital. What are the drawbacks of the decentralized TSSU? That means we'll see that duplication of the area is there, machine, inventory, manpower, instruments, consumables, all like that. So it's a waste actually. If you are having a central department, it is going to be really helpful, and your resources, whatever is there, it is going to be a optimum usage. And earlier, whoever the staff was available for a CSSD means they were actually not working or somewhere from other department. They used to pick and kept in the CSSD. But nowadays, no. We are getting all trained staff for performing the job. So whatever the outcome we are getting, it is a much better than earlier. So even earlier the quality was not proper because at different locations, all this work was done. But now being a CSSD centralized, whatever the quality work we are getting, it is maintained throughout the hospital. So if you are having a decentralized TSSU, there is a drawback that even lakhs of rupees are expended in that. If you are having a proper CSSD, that much saving is done in the department for the hospitals. After all getting CSSD, we have to see that OT and wards are the direct customer of CSSD. In case OT or ward face any challenge in terms of sterile material, CSSD should initiate to find the root cause and provide a proper and permanent solution for their user. And on a regular basis, an internal meeting should be conducted between OT and CSSD if any new requirement is there for sorting the problem as well as for the process improvement. CSSD should maintain a high level of standards in terms of service and quality care to its end user. Thank you very much. I had completed my slides.
Thank you, Mr. Singh. That was a brilliant presentation. The experience speaks for itself.
It was just only on the experience based, whatever I was supposed to deliver, I had given.
Yes. It was very, very good. I will formally, before we go to any further discussion, I will formally thank everyone whom I'm supposed to begin with. Dr. Pragji Vaga, who's our MMC observer. Thank you very much, sir, for taking out the time. We understand that you have to spend actually it became 5 hours now. So thank you very much for being with us and looking after the MMC requirements. I must thank Tushar. We have been screaming his name all through the thing, and he has been very, very kind and very helpful, and without whom the whole webinar thing cannot happen. With that, I thank all our faculty, each and every one. The sessions have been brilliant, and even after 5 hours, our participants are still with us, so that talks about itself. Thank you, everyone. Thank you, Vidya, Aruna, Geeta ma'am. Thank you, HIS Executive Committee. And most of all, thank you, Sarika, for the MMC point and all the other footwork done. Thank you very much to all our sponsors, 3M, ASP, and Raman and Vail, and also Alliance, who became our Institute Life member. So I hope I have not forgotten anyone's name, but thank you very much, participants, last but not the least.
A very thank you to you as well. I think it's been a Herculean task to organize everything along with, Sarika. I think both of you have done a lot of work. Thank you so much.
No, I think I should say the same to you about Aruna, because it was continuous, whatever I couldn't do, forgot, everything was done by you. So, and of course, ma'am's support has been tremendous. So,
I also wish to thank everybody in the organizing committee for giving us the opportunity to talk. Thanks a lot.
Thank you.
We gather also a lot from all other faculties.
Thank you.
It was a brilliant session, all in all, I believe.